whether the infrastructure which is happening in the health sector, in the hospitals, training institutes, nursing colleges, and all kinds of skill development institutes. India is really becoming really strong and strong globally, competing with the best of the countries. If you see the trend globally, the kind of the more than 10 to 15% of growth every year is recorded in the inflow of the foreign patients coming to this country. Of course, majority of them are from Bangladesh, followed by African countries. If you go to any state and go to any good hospital, you will certainly see people from CIS countries, Bangladesh and Africans going from one room to the other room and coming for various operations and other medical facilities. Speaking about Gulf, I know why the Gulf region is very important for our country, because of the overseas Indians, the Indian diaspora living there. More than 3 million people, Indians, are living there. I used to be Tourism Secretary, Kerala government, and during that time I used to notice how many Arabs were coming during monsoon season. In fact, we used to market Kerala as a monsoon destination. So when watching rain itself is something great for the people from the Middle East countries. So they used to come not only as a tourist, but to stay there for wellness treatments, ranging from 1 week treatment to 21 days treatments. And slowly they were not getting time from hospitals from Kerala. They started going to Karnataka, they started going to Chennai. And thanks to the Honorable Prime Minister's initiative and the call about Ayurveda and Yoga, now Ayurveda centers are everywhere in the country. Yoga centers are everywhere in the country. Now it has become holistic. The holistic development of human personality, human health. So we are trying to inform each and every country in the world about our strength in wellness, in Ayurveda, and the kind of pharmaceutical industry which is growing here, the kind of quality of the hospitals that are coming up in the remotest areas of this country. Uttar Pradesh, Bihar, Orissa, these states also you can see the growth of multinational hospitals with state-of-the-art equipment in the remote areas also. So with this, I would like to mention to you with few statistics of Gulf countries, how patients are coming here. From Iraq, number of medical value travelers in 2018 it is 59,258, which has gone to 56,310, and last 2021 15,357 from Iraq. Oman again it used to be in 2018 27,000, because of this COVID and all there was a down. Saudi Arabia it was 4,900, Bahrain 1,458, UAE 987, Iran 249, and Dr. Azad Mopanji, I knew him last 15 years. So people like him, they have gone there and established their hospitals and showcased the Indianness there. And they also do a lot of facilitation, bringing people from Gulf countries to India. In Saudi Arabia, in Bahrain, and other parts also, many patients are doing inquiry. And the portal that was inaugurated in the morning by Honorable Health Minister will definitely be useful for everybody to see that it will be easier for you to access each and every hospital, and the doctors and the specializations in each and every hospital. So that will be is a game changer as far as the logistics for the patient is concerned. I request all of you to speak on the issues which are pertaining to the insurance areas are there, aviation sector is there. In fact, I have requested the Civil Aviation Secretary also, which is confirmed, but last minute he had to stay back because aviation industry plays a crucial role in bringing patients to this country. UAE has got some understanding with the Emirates Airlines of reducing the cost for the patients. Similarly, we are talking to other countries also, CAS countries and SAARC countries, ASEAN and other countries for speaking to their own local airline people to reduce the costing there. Another major aspect was insurance aspect, which I want all of you to focus on. And the hotel industry is also major industry, which plays an important role in reducing the tariffs. What happens in India, all of you know, after October, from October to March is the season for Indian tourism. So when they come, and the hospital rates are really high, particularly after the COVID. In Kashmir, I must tell you this, in Srinagar, per day it is 1 lakh rupees, 1,10,000 rupees in 5-star hotels. Less than 50,000 rupees is not possible. So maybe same is the case in everywhere, Karnataka, Kerala, Mumbai and all. So maybe hotel industry can also take a call in reducing the tariff on that. We will discuss on this. So with this, I conclude my introductory remarks. I leave it to the moderator. Thank you so much.
Thank you so much, sir, for these insightful opening remarks. I'll just request, knowing Gulf as you do, sir, Dr. Bhupan, any opening thoughts?
Thank you. Thank you very much for that also out of turn opportunity. Yeah, I have been there for 37 years and I have seen how Dubai has developed in the, not UAE or in the Gulf has developed. So regarding this session, thank you very much for all the compliments that has been mentioned about me. The most important opportunity, I think, is from the expat population. It's not that we have too many local population in many countries, especially in UAE. The number of expats are only 15% and 85%, I mean, India, locals are only 15% and 85% are actually people coming from other countries. And from in that, a large part of the total number of people are from India. So that's a huge opportunity. But along with that, there is an issue which has come recently where the people don't want to go to their country. Earlier it used to be the first thought in anybody's mind, but they now are covered by insurance. So many of the people would like to get the treatment being done there. So my one important suggestion, if we have to get patients from GCC, especially UAE, is that we should be focusing on insurance companies rather than individuals. Insurance companies make the decision now. For them, it's an advantage if a patient, instead of getting operated in GCC, if they come to India, that's going to reduce their cost at least by 50%. And the patient also is happy because the patient can have the comfort of coming back. Many of them are living there with their families. So they can come back and have the treatment here in the comfort of their families. So that's one big piece which, if we properly do that, addressing the insurance companies and try to get the patients through them, that's going to be a significant advantage. Now, the other very important thing, which I have always felt, is that the Ministry of Health and Tourism, not only of the center, but the states, should focus on GCC as the main market, because that's a place where we have the largest number of Indians. So what's happening now, as has been mentioned by Sir, Kamal Rao Sir, the flow is from, mainly if you take GCC and even the Middle East, it is from two countries that we see. One is Oman, another one is Iraq. The other countries like UAE, Saudi Arabia, Bahrain, Kuwait, these countries, it's just a trickle. This is because they don't know about the Indian healthcare and how it has gone up in the last 15-20 years. We have not been capable of sending that message into them. So there is a requirement for the Government of India, the state governments, along with the hospitals who are interested to do that, to have a very active campaign in these countries, which can be even funded by the hospitals which are participating. We can keep some basic standards like NABH accreditation, and then beyond that, looking at the specialties. It's a great step forward in what has happened today by the launch of the unified, the website. That's a great step forward. But in spite of that, I think that there is a requirement for us to promote India properly, and whenever people there think about illness or wellness, they think about India. And naturally, that was what was happening 50 years back. They all used to come to either Mumbai or to Madras or to places like that. That has now gone, and they all travel to the Western countries. So let us look at these 2 points which I have mentioned, and as we go forward, we can discuss further. Thank you very much for the opportunity.
Thank you, sir. So, without much ado, before I open the discussion, it's my proud privilege to invite any of the invited foreign health ministers, excellencies, in case they are present here. If none, with your permission, Chairman, sir, we can start going around the table. We need to focus not only on the opportunities but the challenges also, as Dr. Moopan has very rightly pointed out. Let's start discussing what all collaborative efforts need to be done, what alternative offerings are existent, what need to be created, what technological interventions are desired, what regulatory framework we aspire to, and ultimately what innovation should be nurtured, whether it's frugal innovation or it's imported or whatever. So please be candid. There's a white paper which will be churned out of all this manthan which is happening today. And once again, special thanks to FICCI for coordinating this. With your permission, sir, we'll have Mr. Faisal. Would you like?
Excellencies on the dais, guests, my name is Faisal Kotikolon. I'm based out of Dubai, Indian, but been in India now for the last 10 years, doing some work on healthcare. I'd just like to share my experience. You know, as we all know, India is a cradle of knowledge, especially in healthcare. You know, because starting with Ayurveda to modern medicine, great doctors all over the world, nursing staff all over the world. And the best way to create a strong brand of India to the Middle East is to start cooperating with those countries, bringing innovation and research. You know, I think many of us forget that. You know, the only thing which I always talk about, knowledge is power. You know, that's a power which will always remain. And I think we need to start looking at bringing research of countries together. You know, and that is something which is possible. Middle East is ready for that because what they have is amazing infrastructure. They have grown leaps and bounds in the last 25 years, and they are going into the knowledge economy now. You know, especially UAE, Saudi Arabia, you all see, they are really trying to go to the knowledge economy. And I think we need to really bring in our knowledge, you know, through research and innovation with these countries. You know, and they will be open to the idea. I'm also talking to a lot of ministers there, and they all love it, correct? I mean, and I think Dr. Azad, myself, you know, we all contribute a lot in research to come to that country. I'm in the board of Sharjah Research Park. I'm board of Jalila Foundation. So we can really bring a brand, because normally the tourism which is coming to India is mainly coming for the cost effectiveness. That has to change. You know, if you really look at it in Thailand, Bumrungrad, I've been there for 10 years ago. That time, 75% of the revenue is coming from medical value tourism. You know, and they started 22 years ago. I always wondered how come we couldn't build something like that in our country. You know, with all the knowledge and the hospitality what we have, we should be building 10 or 20 Bumrungrads in our country, so that we need to attract, you know, high-paying patients to come to our country. Instead of depending only on Afghanistan, and I'm not saying that we should not open the doors, but I think we should also take it to the next level, and I think that'll be my opening comment, and we can discuss further. Thank you.
Fantastic. Thank you so much, sir. Dr. Gyani, sir, you've been the Director General of AHPI, which represent 20,000 hospitals. What, in your perspective, sir, what's your perspective on the collective thought of these healthcare providers? One, for integrated health, and two, how ready we are and what new we should be doing for taking quality to the rest of the world.
Yeah, thank you very much. You see, when you said that we have roughly, I can tell you, around 5,000 hospitals we have in India, 5,000 plus, which has bed size of 100 and above. Now this 5,000, 100 and above means they are primarily tertiary care hospitals, and some of them also the quaternary care. So that is the one strength. The second rung is that between 30 to 100, we have got 25,000 plus hospitals. And then below 30 bed, we have got whopping 40,000 small nursing homes. Now that is the kind of scenario India has. But at the same time, we have a huge population. So this number still, we have to go up and up, because we have to ultimately make the target of 3.5 beds per 1,000 population. So that actually is one side. Coming to your question, you see, actually when we talk of integrative care, many times we sometimes, think that we are going to have cross-pathy between the two. No. Two are going to supplement each other. That is actually the new initiative which Government of India has taken now. Under one roof, allopathy will survive here, and wherever required, our traditional medicine, which we call Ayurveda, Unani, Siddha, Homeopathy, they are going to be supported. So there are many cases, for example, when the chronic diseases are there, then we are going to supplement that to the allopathy. So this is the emerging trend in India, and let us be very frank about it, that in this area we definitely have expertise of high order, which we can share with our friends who are sitting here. So I think, and of course, otherwise, as you know, that Dr. Kocher is currently heading our accreditation board, and the kind of, the accreditation has made an impact in our country. The patient safety indicators have really gone up now. So I think the kind of which impression that it is only the cheap healthcare, no, it is now cheap and quality healthcare with the proven clinical indicators. So I think India is today offering the kind of services which I will suggest, Dr. Kocher, we should be aiming at capacity building in our other countries, not simply, one-time partnership. We should be helping each other so that we build capacity on permanent basis wherever we have strength, and similarly, where they have strength, we can take their help, and ultimately, by, the message is build capacity in each other. Thank you very much.
Very, very rightly said, sir. COVID has also taught us that we cannot survive by creating islands of excellence. If we have to reach out, we have to raise the quality of everyone. We are as strong as the weakest link in the chain, and we must concentrate on this herd quality concept, if we can say that. Dr. Shahid Merchant, sir, you know healthcare very well, and you understand India also. You are partnering with the Gift City also.
Yes.
We have realized. What are your thoughts on the entire?
Yeah, so I think my colleagues and Dr. Asad Mupin said us very clearly, and Mr. Faisal also, on how to show India on the world map and get more work coming to India. I give you a simple example on advanced heart failure. Now, this is a condition. I was there a couple of days in Dubai, and I gave a couple of presentations to different specialists, and I was surprised that even basic, guideline-directed medical therapy was not known to many cardiologists. We get references to India from Cleveland Clinic in Ohio. I'll tell you a recent example of a patient who was a heart failure, advanced heart failure, at the Cleveland Clinic in Abu Dhabi, and the Cleveland, Ohio cardiologist came and put an LVAD, and he went away, and then the patient went into biventricular failure, and Dr. Faraz Badar, who is chairing the heart failure at the Cleveland Clinic in Abu Dhabi, gave a call to me and then also to my colleague Dr. K.R. Balakrishnan for a heart transplant. In a private plane, we shifted the patient from Cleveland, Abu Dhabi to MGM Chennai, MGM Healthcare Chennai, and we stabilized the patient, and patient was in severe right ventricular failure and just needed some adjustment on the LVAD setting. It was Emirati National, some big guy, that was what was told to us, and he didn't need a heart transplant. He just needed a medical stabilization and intra-aortic balloon pump, and we just did the setting on the LVAD, and patient was fit and fine, and he came in a private air ambulance but went home smiling from Chennai back to Abu Dhabi. So this is what India is all about, and as Mr. Faisal said, and as Mr. Dr. Azad Mupin sir also said, that besides concentrating on the expatriate population who can be covered with insurance, we have to catch the insurance companies in the GCC to allow our expatriate population to come here, because we have knowledge, we have technology, we have science, we have research. We are already working on manufacturing both the LVAD for advanced heart failure and also the pump catheter, which are very expensive. We get it from the US, like an LVAD cost 1.25 crore, but the kind of LVAD that we are already working in sheep, is going to cost like 15 lakh rupees. Similarly, Impella for advanced heart failure, where we do procedures, I'm coming with a pump catheter, and I must thank Faisal for introducing me to the university, Sheikh Mohammed bin University, and took me to the animal lab, which is a sheep lab, which I'm developing for them to develop my pump catheter. So this kind of knowledge sharing, as Mr. Kochar said, could help both our countries go in a big way and put India up there, and just not look at medical value travel for patient to come for cheap treatment here. This is my thought, but I'm open to any discussion. Thank you.
Wonderful, sir. Thank you so much. I think from the traditional medicine, which is 4,000 years plus, to the current innovation, which is frugal yet cutting edge, I think India is the destination to be. But Dr. Bishnu, sir, you have helped incubate the Fortis Group. How strongly you believe in the integrated health? What are the challenges, the opportunities, what more we should be doing?
Thank you, Dr. Kochar, and I'm Dr. Panigrai. I'm from Fortis Healthcare as a group head for medical strategy and operations. But here I'll speak on behalf of FICCI, because I'm part of the Health Services Committee of FICCI. And first of all, I'd like to thank the government for setting this conference in play. And the portal that was launched, I think, so is a huge advantage going forward. So I'll take off some things from what Dr. Rao, Mr. Rao mentioned, I think so, on the business part of it. Being a doctor, we look at how do we enhance care. And so the most important thing going forward, if you have to look at the long-term thing, is what is the value proposition you are getting to on the table for the patient. I think so that needs to be marketed. That is what I say is that will take care of the business angle to it. So we just do the cases, whether it's a surgery or a treatment, but the outcomes part is not captured. So what I'm trying to put at is that now this digital health mission is coming up. I think so we should be looking at it, Dr. Kochar, Dr. Gyani, I think the Quality Council also is on it, I think so. Some mandatory fields have to be there in the digital platform that we are coming up with for any patient going to any hospital being treated, big or small, public or private. because that will then give us the data on the outcomes that patient has, whether it's for a lap chole or a bypass surgery or a PTCA, whatever it is. This is not being captured. This will be a huge gain, and because we have the mass there. And when we look at, we are talking about GCC now, Dr. Mopen rightly mentioned, the huge expat population there, we are not showing the value proposition to them. So, I'm just giving example. Just last week I was sitting with one of my cardiac surgery colleagues from AIMS, just not like his name. A patient had gone to Texas Heart for a complex aortic surgery. And it was $110,000 there. Why you want to do it there in AIMS or in Institute of Medical Sciences? He came and it cost $2,000 total. So where is $2,000 and where is $110,000? And he mentioned that probably if you go to him, his outcomes are better because the volume of cases that he does is huge. So what I'm coming to is that Dr. Bala is a very good friend of mine. He was in Fortis also. I think so. We have to also look at, when we look at getting patients from other places, we should identify centers which have a volume base. Because what happens, there will be multiple hospitals, they will be doing 1 or 2 cases, and we are diverting patients to them. That's not fair to the public, if I can put it that way. So like Dr. Kocher he leads the NABH thing. For a hospital to be NABH accredited, they have to have at least 30% occupancy, am I right? So that's the minimum mass volume that has to happen. I trained in New Zealand. I remember in the University of Otago, when I went there, pediatric cardiac surgery has stopped. So I asked the professor why he said, we were not doing number of cases because the antenatal screening has improved. We just do it at Green Lane in Auckland. It's easy to, it's much economical, and most important tool, which is very important to put on the table, is that because the number of cases are so low, our skill sets go down. So if you have to give, the value proposition has to go up. You have to have a mass volume there. You have to create your outcome, capture the outcomes. So on the digital platform, I think so some mandatory fields have to be there. We are rolling out our digital missions, and all the private healthcare providers are now also having. Some of them have the EMR. Some of them are trying to have the rolling out the electromedical records systems. I think some mandatory fields were there, whereas irrespective of public-private, this gets incorporated. And so this is what I want to say. And the health insurance part, which came up also, I think so we should be looking at how do we ensure that the health insurance there has a link up with our insurance providers here, so that it becomes a seamless way for those patients and the relatives to come, and otherwise they are running around from here to there. Thank you.
Thank you, sir. I think that's very well put. The value for the patient, the outcomes must be captured, and insurance products to be tailor-made for such cases. I think there's lots of logic in that.
So Dr. Kocher, value is outcomes divided by the cost.
Absolutely.
And Indian outcomes are very good, but we don't market it.
Market it such. Yes. To marketing, as Dr. Bhupan also very rightly said, currently majority of our Gulf marketing is limited to Oman and Iraq, and somehow the UAE, the Saudi, the Bahrain and the Kuwait are, we don't project ourselves very well. So we'll quickly go around the table. I'll request for any of our foreign guests, in case they are in attendance, and please introduce yourself in case anyone is present. Otherwise, we go around the table. Please, I'll be grateful if you could just switch on your mics and we take one on one. Please have a quick introduction. Yes, sir. Please introduce yourself, sir, and your comments or suggestions.
I am Dr. Minocha from Mary Life Science.
Sir.
I have heard the certain people from the dais very well said so many things, and I think I'm just trying to say how we can add those things where we need to have market access in different countries. That's the key thing. Now, this is something, what we do it in India. This is an eye camp. This is an orthopedic camp. Now, something like that, if hospitals, industries, those who are supplying the equipment or those who are supplying implants, now they need to have some sort of expos or some sort of conferences where we market ourselves, we showcase that this is what Indians can do it, this is our hospitals are doing, this is the value proposition, and this is how our cost will come down. And country by country, and ailment by ailment, if we go, see, it's very difficult to have such kind of big G20 kind of summits everywhere, I can understand, because we have to ultimately look at that we should have a patient pool. Now, here again, let's say we have the experts already here, right? And we need to train them. We in India also offer the training facilities. We know that in India, certain industries and certain companies, they have training facilities also. And newer products, innovation-based products, we can offer them. See, I can tell you yesterday, in cardiological interventions, when bypass surgery was to be replaced with stenting, now this stenting has become common in everywhere. Now today, if robotic surgery has not become common, and already robotic surgery has already been established in India in more than 70-80 centers, that means why can't we have this a robotic surgery kind of platform where we can showcase, do the demo, and I go a little one step more. See, the manual surgeries basically have, let's say if it's a knee implant surgery, for example, it requires 100 to 200 kg of surgical tools, power tools, and then manual navigations, lot of complications, and lot of expertise. Certain expertise may be as good as robot, but not all. Now, under such situation, the robotic surgery, which can be done with the help of only 1 or 2 knobs, and you can achieve the surgery. Now, as I think, I'm also aspiring to do the innovation in a different way. The robots, ultimately, they are used with, say, a keyboard, voice command, and we have the surgeons. The assistance can be done at the places. There are also operation theater. Our expert can do the surgeries using 5G kind of connectivity. They do the procedures, they are assisted by them, and we can make them popular. So there is enough scope to present. For that, we need market accessibility. And when it comes to the accessibility, we have to make ailment-wise group from industry and government. And we should create some kind of summits, some kind of conferences where all should participate and bring them a population, a minimum population, because many of the surgeries are not accidental, they are planned. So if we can do it properly, say for 100 surgery in this particular city or 500 surgery in this particular country, this is how we can make India visible. This is my opinion.
Thank you so much, sir. I think that's very well put. To have ailment-wise group, develop certain standard treatment guideline, or develop certain core expertise in certain areas. I think that's a very good out-of-the-box idea which we've got. If we could quickly go around and generate about 10 big ideas or suggestions or guidance for everyone. I think Secretary Sir is also here, and if we could have the proper one big idea each in one line, what would that be? Yes, please. Please introduce yourself. And
good afternoon, everyone. Thank you, eminent panelists, for giving us this opportunity. My name is Sanket Arora. I represent HCG Hospitals. Now, since the discussion, besides discussing the continuum of care, has also been expanded to discuss the challenges, I'll lay before you 2 practical challenges which we face while, doing business in Gulf regions. Number one is capacity building. Now, since one of the theme of One Earth, One Health is also healed by India, we intend most often to take our medical experts to countries like Oman, Bahrain, Yemen, not Yemen, but in, Iraq and all. The challenge we face there is, getting registrations and licenses of these doctors in these countries takes a lot of time. And this is especially so in Gulf nations. So the request and the thought that I lay in front of the eminent panelists is, if our medical council, the National Medical Council, can liaise with the local medical councils there and hasten this process, it will really help us not only in building the capacity for these hospitals whom we partner with in these countries, but also the complex surgeries that we intend to bring here can be, we can have a collaboration in that. The second challenge we face usually while handling business from Gulf countries is, as Dr. Mupan said, sir said, insurance. Now, while handling insurance, the risk that individually we hospitals have to face is the risk of defaults, basically the payments and all not coming in time. And there are some countries which where we face a lot of challenges where we have to have extended exposure in terms of the payments coming back. So there, if in case we can have the local insurance companies liaise with our bodies like IRDA and have a formal kind of an association, that will help us in streamlining and hedging those risks for the hospitals, because currently we are directly dealing with them, and of course the risk is with the hospitals to deal with. So these are the two thoughts that I had wanted to
Thank you, Mr. Ankit. I think these are again very well taken. Capacity building, liaising with the respective state councils, and association or associating with IRDAI for packages. Yes, Danish?
Thank you, sir. I would like to make a suggestion, or also, based on what Mr. Kamla Rao sir also pointed out. Most of the experience of the patient when they come to India, happens outside the hospital. They stay in the accommodation before the treatment. They stay in the accommodation after the treatment, and that is where we need more standardization and more accreditation, because that is where the infections happen again. That is where the experience gets ruined. We are one of the largest medical travel companies in the country, and we are getting patients to India. Although our hospitals are world class and we are able to give them the best facilities, it is outside the hospital that also we need to sort of look at and see what we can do to improvise on the standardization on where the patients are staying. Thank you, sir.
Thank you so much. I think with the launch of the portal, hospitality for the attendants as well as the post-op part is also being taken care of. There's the grading of all these facilities also in the offering, and that will be prominently displayed. We have final 5 minutes for comments before I request sir to close. We are yet to cover innovation. So what innovation, anything, please.
Yeah. Hello everybody. Sir, I am Dr. Nishita and I am representing
You'll have to speak a little closer, please.
I am Dr. Nishita Shukla and I am representing Shalvi Group of Hospitals as in Group CEO. Sir, all concerns and all points were very genuine related to international patients. If I take this platform to convey it that we sitting in Ahmedabad are world leaders of doing orthopedic surgeries. So we do highest number of replacement surgeries in world. So again the marketing part comes in where people still are not aware about this, where we would request government to give us some platform or give to everybody. Certain hospitals are good at cardiac surgeries, doing highest number of cardiac surgeries. Certain hospitals are good at certain specialities, where we can have a platform where we reflect it directly to the patient sitting over there. Because as you know, there are a lot of mediators between this and there are a lot of competitions going between hospital in, fetching the patients and all. So a genuine help will be there, like, the patient can access the doctor on their own, having the understanding of the number of surgeries, the outcomes, and the, the gradations, like the degrees, the gradations, their experience and, the outputs. And second thing is, I would like the TPS company to be giving their packages and rates as per the quality of the hospital, as the standards of the hospital, as per the seniority of doctors working in that hospital, so that there is a uniformity between good high-end corporate hospitals as well as nursing homes and all. So these are two major points I would like to have. And definitely for the aviation part, sir, we need more flight connectivities to Ahmedabad.
Absolutely. So, as sir mentioned, the Civil Aviation Secretary was to join. No, but I think the very fact that government has taken note of all these policy matters, brought everyone together, and now there's a single line of command flowing from the Ministry of Health and Family Welfare, being the nodal agency, there's lots of optimism and positivity. So any other ideas, quick thoughts, suggestions? Anyone? It's a opportunity to speak out. Yes, sir, please.
Good evening, sir. First, I would like to introduce, I am B.K. Singh, Joint Secretary in the Ministry of Ayush. And we want to inform regarding to all the participants that two initiatives taken by the Ministry of Ayush. One is the Ayush Visa. It is now notified and in place, and it is available both for patient and attendant also separately. Along with that, we are also going for some kind of listing of hospitals also with the best facilities, so that at the time of choosing, at least there should be knowledge where he is going. For Ayush Visa, same condition will be there, that you have to take the recommendation of the hospital where you are going, and like medical visa. And second is that in most of the hospitals we are going for the integration of both Ayush also and allopathy medicines also. In case of Delhi, most of the government hospital has already this facility. AIMS, Safdarjung, RML and Delhi, Irvin, all hospitals have this kind of facility, and in fact, in coming days we are going to have this facility in most of the hospitals. In case of private sectors also, those hospitals who want to integrate it, they want to have this kind of facility, they should do. I think most of the patients coming here, in case of preventive itself or after operation, it will be working very well. This kind of facility, Ayurveda facilities and Panchkarma, whatever we. For that, again, I request private hospitals to take these facilities in their own infrastructure. We can help in developing those, and we will be coming forward.
Right. Thank you so much. I think this has been a wonderful discussion. We have spoken about innovation, research, capacity building, marketing properly to various our populations globally, develop market access, think about value, the outcomes, ultimately think about insurance packages, customize them very well, tailor-made, better the facilities, TPAs, etc. I think there is lots of learning for all of us. We'll collate everything and circulate a white paper. But before that, I'll request Secretary to the Government of India and CEO FSI, Chairman Sir, Mr. G. Kamla Rao Sir, for his closing comments.
Yeah, thank you so much for that interesting comments came from, and the responses on how to promote medical value travel in this country. And one aspect, which I think which just we missed out is the role of the facilitators. Once anybody is coming from other country to India, the first thing is the trust and the confidence. So unless he knows the facilitators, whether they are accredited facilitators or not, what kind of quality of the facilitators, how are they trained, and next comes the logistics, the aviation thing, the visa regime, and coming here, and the hotel accommodation, and nearby homestays and other things will come later. First, the trust is important, whether he is not being duped by taking him to Chennai or Mumbai or Kolkata. So these facilitators, that is one thing which entire industry must think about training. Archaeological Survey of India has got notified guards, the translators, everybody is notified by Archaeological Survey of India. Similarly, the facilitators also, they will have to be certified facilitators, notified facilitators, and also they should be given certain kind of training, how to handle the patients and how to do the... so that trust and confidence for the facilitators is very important. National Health Department has constituted a National Tourism, National Development Board, Medical Board is there. Tourism Department also has constituted one board. And ITDC, in fact, Tourism Development Corporation is notified as a nodal agency for getting play the role of a facilitator to enhance the feel of confidence among the foreign patients. Okay, so this is one aspect which I think in Gulf countries, people like Dr. Azad Mupanji and others can create a set of group of facilitators, maybe an agencies, with the help of the state governments. We'll be definitely requesting state governments to come forward and set up institutes for the training. Each and every state government, let me tell you, they have institutes on various aspects of the training. Skill Development Ministry itself is a huge ministry which is created recently and which has got thousands of crores of budget to go for skill development of various skills in the country. See, this is MVT, the Medical Value Travel Development is an inclusive development. Every ministry has to come forward, whether it is aviation, whether it's Ayush, as the Joint Secretary Ayush is mentioned here, the Commerce, so the Health Department, Tourism Department, all of them, MEA, Minister of External Affairs, he has mentioned about Ayush Visa. See, earlier we were having only we have business visa, you have tourist visa, you have student visa, then medical visa was introduced. Medical visa for the patient as well as for an attendee. Now Ayush visa also is introduced with an attendee. You know, this has to be given much publicity there in Gulf countries, and I'm sure with the support of the industry and the state governments and private sector, we will definitely get more. See, the point is that, you know, doctors and advocates, we can't say wish you best of luck. We are not saying that, no, we want more patients, but only thing is that, no, whoever is getting disease and unwell, instead of looking to other country, they should look at India for the infrastructure and all. One point is about the Indian diaspora plays a major role there. I think Indian High Commissioners, we are in touch with Indian High Commission, Indian ambassadors to play a positive role and proactive role in activating the Indian diaspora, who can speak about the strength of this country, strength of the state government. If a Gujarati is there in Gulf, he'll speak about the strength of Gujarat. Telugu fellow is there in Gulf, talk about the strength, about the hospitals there back home. So these are the areas which I thought, you know, we can together, the industry and the government, travel together to promote India as a major destination for medical value travel. Thank you.
Thank you to all the esteemed panelists and the participants for very insightful discussions. We'll have our next regional roundtable here for SAARC and ASEAN region. For the CIS region, we'll have it in the Seminar Hall 1. Please do join us for the roundtables. Thank you.
टेस्ट करते ही ये इस पे आ जाएगा।
Yes, good. आया
ऑफ करना होगा ऑफ करना होगा अगर हम 2 माइक एक साथ
Good afternoon. Good afternoon once again, and we are here to start this new session, and which is the power of partnership and collaboration for effective health service delivery. Now you see that theme of this conference has been One Earth, One Health. Now this goes from the simple, point that each country will have some strength and each country will have some gaps. Now this purpose of this meet is to see how we can help each other by providing support where we are strong and taking support where we have the gaps. So this is the whole, scenario which we are going to discuss today. Now, my name is Dr. Girdhar Gyani, and I am, I'm just waiting for. So welcome to Abhishek Singh, who will be chairing the session. So should I give a little background and then I will hand over to you? Sure. Okay. So what I was saying that this session actually, as we are going to discuss the partnership and collaboration for effective health, I was trying to, visualize, going by the previous session, that when we are saying partnership, now one is that medical tourism we have been discussing, that okay, we get the patient, we send the doctor, we send the allied healthcare worker, one time kind of, help. Now that is not going to really help the kind of summit which we are organizing. Our aim should be that if I have got the strength, how can I help my other countries through capacity building? That means, for example, I will give a few examples which I noted down when I was sitting in the last session. For example, each country has got, the objective of universal health coverage, because that is the overall objective. Now, that component of the universal health coverage are making healthcare available, making healthcare accessible, and making healthcare affordable. These are the three important elements of universal health coverage. Now, availability is the most important one, because availability means providing number of beds, providing number of doctors, nurses, allied healthcare, SOPs and all that, Now, that again, is going to be a kind of one-time effort, that we can lend the doctors for some time, we can lend the nurses for some time, but that is again one-time effort. Now, so I thought I'll give you just 5-6 points before I invite the session chair. For example, these 5-6 points are, suppose I have got strength of planning and constructing the hospitals. I can provide that expertise to the countries and they can build the hospitals and, the necessary infrastructure, including the architectural aspect. Number 2, adopting the best practices for hospital operations. Now, this has been identified as one of the weakest area in many of the countries. That's why the cost of healthcare is going up. We have to learn how automobile industry, for example, the way they have achieved the expertise, they are using Lean, Six Sigma and other tools. And that's why they are very cost competitive. We have not done that in the healthcare. So we can help in adopting these kind of practices. Train the trainers on quality and patient safety. Now, this is one area. Once we train the trainers themselves then can expand and multiply in their own respective country. Developing accreditation board. For example, India has got the accreditation board which is operating for past now 18 years. We have the expertise of helping others country to help establish their own accreditation board. Exchange of clinical and managerial indicator and benchmarking. Very important aspect, how do we benchmark between ourselves to see that how can we improve. Help on promotive and preventive health. One study which was done about 10 years back, it says if you spend $1 on preventive healthcare, you can save $5 on curative healthcare. So many times I think we miss out on this very important aspect. Exchange of specialists in the key areas. And they go there and develop the fellowship program. For example, I am talking particularly for the area like organ transplants, that kind of area we can have exchange. And of course, collaborative in setting up of digital hospital, very important area. A smart hospital or digital hospital. In India particularly, I can vouch here, We are the leaders in the IT. We are helping America and other European countries. Why can't we help in healthcare the same way, including putting the electronic medical records on the clouds? And last one is, very important one is that we have to come forward together now and establish the mutual acceptance of the qualification of the doctors, nurses and paramedics. That is a big problem today, I find. Many countries do not recognize. So at least in this group who are sitting here, we can do that. And last point from my side is that we have got Indian Medical Association here. We have got Association of the Hospitals. So similarly, Association of the Hospital of all the countries, we can come together and exchange the various problems which we are facing from hospital to hospital and similarly doctor to doctor. So I am offering here on this platform that we can evolve from day one, this kind of association. So I think now, of course, we have got two eminent ministers and I will be inviting them. But before that, let me ask the session chair, Mr. Abhishek Singh, to give the opening remarks.
Dr. Girdhar Gyani, Director General of Association of Healthcare Providers, Excellencies, Ambassadors, members of the industry, it's indeed a great pleasure for me to chair this session of so many eminent people from ASEAN and SAARC region and also from our industry. I have just completed a session with the African countries, and there we could come with some very new ideas, and this is the whole purpose of such a discussion, that we look at the current available avenues of cooperation and also forge new areas of cooperation. We had a very dynamic session in the morning led by our honorable ministers, where they have given guidance to all of us as to the way forward. And we also had a very good launch of the portal, which was highly appreciated in the session that I chaired just before lunch, just before this session with the African delegation. And there were, the themes that were discussed with the African countries. I think many of the themes are also similar in this session also. When we look at, health, the theme of today's discussion is One Earth, One Health. So there has to be a universal element to health that is most important. And I think in India's G20 presidency, that has been one of our important markers. And with the key principles of equity, affordability, universality, India aims to provide universal access to quality medicine through increasing access, increasing affordability, and by lowering the cost of healthcare delivery and equity. If given an opportunity, India can produce generic medicines and meet the world's requirement of medicine, especially by producing life-saving drugs for the less developed countries. Friends, our companies, I can name some of them like Cipla, Sun Pharmaceuticals, Biocon, Bharat Biotech Limited, are one of the leading generic drug companies in India that are rapidly expanding into new markets such as the African market, the South American market, and are also planning to enter the Middle East market soon. With collaborative approach, and that is the key word, relevant collaborations, via ASEAN and SAARC, we can achieve India's goal of Vasudhaiva Kutumbakam, which means that the world is one family, by providing affordable, innovative, and quality pharmaceuticals and medical devices across the globe. Excellencies, friends, the need for partnership in the health sector has long been emphasized as a vital element in enhancing resilience and preventing health emergencies like COVID-19 outbreak. However, collaborations can be a catalyst for change, higher accountability, improved patient safety, and generally better health service delivery, in addition to boosting global security. in May 2022, talking in context of ASEAN, India-ASEAN partnership was formed for the strengthening of global health that resulted in 3 elements. One was the sharing of technical expertise, a critical element, I would say. Joint training programs for human resources for health, which Dr. Saab, you had also mentioned, and for data sharing mechanism. I think India's leadership in the IT sector will also revolutionize the data sharing mechanism, also relevant for our ASEAN and SAARC region. India's powerful technical expertise, excellencies, and human resources for health were enhanced through technological advancement and data sharing mechanism prolific in the ASEAN region. These types of collaborations allow for improved integrated care through data sharing mechanism or virtual value-based care and better health outcomes for patients. There was a very good discussion in the previous session about medical value tourism. So somebody mentioned that medical tourism was always, in vogue for a long time. But now we have this element of value in between, and that is the game changer. Excellencies, friends, as a founding member of SAARC, India is committed to strengthening regional cooperation through various initiatives like building awareness of medical value travel that I just talked about, share technologies for health service delivery, which is also the focus of the discussion that we will have, virtual healthcare like telemedicine, funding and resource optimization. I think telemedicine and virtual healthcare is one element, but we are also looking at, the expertise that we have in form of our very talented and knowledgeable doctors and nurses going to these countries and bringing healthcare to their doorstep. India aims to enhance more effective and efficient development, ensuring progress in the healthcare systems of all the countries in the region, and we are looking for suggestions, ideas, and a brainstorming kind of a session like this one to how we can achieve this goal. Excellencies, you are also aware that India is the world's 3rd largest hub for startup ecosystem. It holds the capacity to co-create similar ecosystem. So we don't have only the ecosystem here, we are ready to co-create this ecosystem in various other developing countries and friendly countries in Asia, in ASEAN region and in the SAARC region. Fostering partnerships and collaborations can contribute to diverting investments in technology startups and joint health development projects in other countries to encourage innovative ideas, quality pharmaceuticals, and emerging tech medical devices. Excellencies, you are aware that India has a reputation for being the pharmacy of the world, and it is not without a reason that it is called so. Till few weeks back, I was Indian ambassador to a South African country, Venezuela. And I went there during the start of the pandemic. And the first duty that I performed there was to hand over 4 tons of COVID-related medicines to the government and the people of Venezuela. Of course, they received such, help from other countries also. But I remember the kind of goodwill at such a critical time that our, small donation or gift to the government and the people of Venezuela created, they still remember. And we have, of course, had many other elements of collaboration. In conclusion, Excellencies, I would say that as India holds currently the presidency of G20, we can provide affordable healthcare to all and to take forward India's vision of one world, one health. I would encourage ASEAN and SAARC countries to join hands and also support us in our journey of universal health coverage. With the support of South Asian and Southeast Asian countries in promotion of this healthcare that we are talking about, we can further explore opportunities in joint recognized degrees. Of course, that is a complicated thing. There are many elements to that, but that can also be in the realm of discussion. We can further explore opportunities to ease the process of our health professionals to share the best practices. I think till the time we have a good exchange of best practices, I think the job is still incomplete. We need to share our best practices with our friendly countries, with the countries of ASEAN, with the countries of SAARC, with all these countries we have shared values also, and to have something like a student exchange program and access to research facilities. Mr. Gayani, I look forward to hearing the panelists today, the distinguished panelists who have come to the beautiful state of Gujarat, to the wonderful city of Gandhinagar, and I also look forward to hearing some comments from the experts who are there in the room today, so that we can take these as inputs for not only for the Ministry of External Affairs, but also for the other relevant ministries in the Government of India. With these words, thank you very much, and I look forward to our discussions.
Thank you very much, Session Chair. And before we invite the expert opinion from the delegates, I would like to invite our special invitees, His Excellency Mr. Shah Mahir, Minister of State in Government of Maldives. We would like to hear from you what you think about the partnership and the theme of our summit.
Thank you very much. Excellency, Chair of this session and Co-Chair, dignitaries, ladies and gentlemen. A very good afternoon to you all. Namaste. It's a great pleasure for me to be here with you today in this discussion. Especially before I start, I'd like to thank the Government of India and the organizers of this conference, inviting us to be part of this conversation, and then especially to talk about this partnership that we are developing, the power of partnership, collaboration for effectiveness of healthcare delivery. This partnership can be defined as the organizational model that brings groups together, governments and also private parties and stakeholders together. And we have a common goal. The goal is to deliver healthcare without any difference, without prejudice to all, and one earth, one health is the right, it's exactly the tone that we need to set. In this partnership, I see three themes. Firstly, there is a relative sense of equality between the partners. Secondly, the mutual commitment that we agree for the common objective we have. Thirdly, the mutual benefit for the stakeholders involved in this partnership. Ladies and gentlemen, the world is in transition, in a great hurry to move with fast-moving changes in the geopolitics and socioeconomic and environmental scenarios. It is unfolding right before our eyes in such a fast speed. A clear vision for our future becomes all the more important, necessary, and it is important for our people. So the challenge in the task may be, the question is, will all the techno-friendly advances that we are making, they are also eco-friendly? Will the economic reform also benefit the marginalized and the dispossessed? And in health too, will it tend to hang in the balance, delicately positioned between the haves and have-nots, between excess and deprivation? This partnership can be harnessed judiciously to facilitate the reduction and mitigation and elimination of these disparities. Therefore, in our vision of the future, we need to see the ethics prevailing, where health will be enshrined as a fundamental right of every citizen of the world, regardless of the race, color, economic, and social status. People's perspective to development will need to be recognized. Having said that, to deliver healthcare up to the expectations of our population is a challenging and expensive task. Maldives, as you know, is an archipelago of a chain of islands, 1,192 to be precise. It's 800 kilometers from north to south and 120 kilometers wide. And the total surface area is 90,000 square kilometers, out of which only 300 square kilometers is the landmass, which means less than 1% is land and the rest is water. So you can imagine to deliver healthcare in a geographically challenging setup is extremely difficult, and it has its challenges. We have a population of approximately 500,000, including the 500,000, including the expat population, and we have 19 atolls. We have 187 islands populated, inhabited, and every island has a health center, has a pharmacy, has a nurse, and has a doctor. That is the bare minimum that we have to. And that is, sometimes the islands are 200 people living in one island, ranging up to a couple of thousands. On average, it will be 2,000 to 3,000 people. And bigger cities, we have more people. And majority of the population lives in the capital city. About a third lives in Malé, in Greater Malé area. So I just put it there so that you also appreciate the kind of health system we are having to address. And we have a three-tier system where the primary healthcare, tertiary, secondary and tertiary healthcare. And we have 5 functioning tertiary hospitals. There are 2 private hospitals, and one of the owners of private hospitals from the Maldives is joining, Mr. Nasheed, to us to enrich our discussion. And we have, in our health system, we have gaps where complex, difficult surgery, difficult treatments are not available. So we have affiliated with many of your hospitals in India. 30 odd hospitals are affiliated with our ASEAN, the company. And approximately 3,000 to 5,000 patients will be coming to India for various treatments. So we see this as an extension of our health system, because things that we cannot do over there, we are grateful to have this opportunity. At the same time, we do want to stand on our own 2 feet one day. So our key is to be able to develop our health system and our capacity so that we don't need to depend as much. Obviously, always there will be advances in medicine, technology. We will not be able to cope, we will not be able to catch up with that. So so in that background, there are improvements I feel we could bring about. And I was very pleased the technology app was launched today, and I think that would add value to what we have to do when we are referring patients. But I think even then, we could also smoothen even further when patients are due to come to, when we're referring the first referral, that technology can be used to make that referral. Some of the tests, investigations that are done locally can also be delivered or could be sent to the hospital they're coming to see, or even to see the doctors, that to build that trust. Nowadays, when you have telemedicine and technology available, the teams can actually, the patient themselves can be familiar with the surgeon they're coming to see. That would build trust even before they arrive, and they know who they're coming to see, and they'll build that trust. So that I feel that even that using technology at that level will also be very important. And most importantly, when they return back after the treatment, to have comprehensive notes, medical records, so that our local doctors can follow those instructions. And there's much more clear, rather than the patient carrying a bunch of notes and pieces of paper which they lose. But if our systems can be linked to the systems where the hospitals are providing here, I think that would even be strengthened, even it would be better. So I think those are, we look forward to hearing from the experts and the hospitals and the stakeholders here. But I think for us it's very important this process to be streamlined, because we heavily currently depend on this system as part of extension of the care that we cannot provide in the Maldives. So I think streamlining this system would be really beneficial, mutually beneficial for both our parties. I wish you all good deliberations, and I'm very keen to hear what people have to say. Thank you so much for listening.
Thank you so much. I think he has summed up very briefly, the whole system of what is operating in Maldives. And this, record transportability or interoperability is being, introduced in our country through the National Digital Health Mission. And I'm sure we will be able to do that jointly and provide the same support at your country.
Thank you.
But now I think before we go to other delegates, with the permission of Chair, may I invite His Excellency Dr. Kehelia Rembuk Vela, Minister of Health from Government of Sri Lanka.
Good afternoon, the Chair, the members of the head table, the distinguished guests, invitees, dear friends. It is a privilege to address this gathering here today to acknowledge the Supreme Progress Health Partnerships making the quest for excellence in what we do. Today we face global as well as local threats to health. The recent pandemic, infectious diseases and non-communicable diseases have staggered and staged a dramatic comeback. HIV, Ebola, SARS and avian influenza almost seems like a distant memory compared to what we have endeavored in the recent past, not to take anything away from the severity of those issues. Appreciating wisdom and prudence within the planning, priorities set in, and execution of initiatives has become paramount. Health is no longer an abstract issue at global and national levels, but rather a concrete reality that impacts individuals, households, and communities today. The quest of most states or governments to adequately cater for the healthcare needs of its people continues to be a difficult task, as many states have experienced and continue to experience a reduction in allocation of resources to the health sector. The involvement of the private sector in the healthcare delivery is an alternative being explored by a number of states to augment the resources in the health sector. These alliances are being explored with certain partnerships between the public and the private healthcare facilities in the fight against AIDS, tuberculosis, and malaria. COVID-19 has thrown into bold relief the need for a united cumulative response, supported by regional and global partnerships to control the pandemic. Addressing the social determinants of health, universal health coverage, the non-communicable disease burden, other communicable diseases, and the achievement of the Sustainable Development Goals would require a close collaboration among different sectors and stakeholders, including the private sector. Partnerships imply three fundamental things: relatively equality between the partners, mutual commitment to agreed objectives, and mutual benefit for stakeholders involved. A typological classification would include technical assistance partnerships supporting services, access, and provision of services, including drugs. Partnerships focusing on research and development, advocacy, resource mobilization, and financing partnerships would mainly focus on providing funds for definite disease programs. Partnerships in the health have brought and continue to bring multiple benefits to the countries. They also, however, provoke several challenges, including the duplication of effort, waste, high transaction cost, issues of accountability, and the consequent lack of alignment with the country's priorities. It is not ambitious to attempt the elusive idea where all parties will benefit from one another with a give and take between the stakeholders. Partnerships in the health could well announce a new dawn for health development in Southeast Asia region. We will continue to engage strategically in partnerships for health, strengthening relationships with civil society organizations and the private sector, and create greater alignment between partners. I aim to work closely with our partners in the United Nations system to usher in reform that enhance the effectiveness of the UN, especially at the country level. A strong partnership, especially with neighbors, is essential throughout our line of work. I can never overemphasize this. As we have witnessed in the recent past, our neighbors have sometimes been the reason we've even survived. I want to take this opportunity to thank you for your support and advice as we sharp the road ahead for better regional and global harmony. Individually, we are just drops. Collectively, we make mighty ocean. And I must say that during the time of the pandemic, as we all experienced, that is a lesson to be learned, in fact, as a practical situation, where we were all helpless and we really did not know as to where to do and what to do and when to do. And fortunately, I think I must say that I'm really proud of our health sector at that point in time, when the whole world were looking for new ways and mechanisms as to how we could curb this. We were able to, in fact, set up a thing called home management system, where we had 141,000 people were treated, only one death. That's a record. In fact, WHO has taken that as a sort of benchmark activity that we created. We created, because we have 5 government officers in every village. So we made use of them, and we had call centers all over. Anybody could send a message or give a call. We guaranteed them within half an hour that somebody will call at the residence, and we were able to do it. Moment they were called at the residence, we gave 2 weeks provisions to them by the government. And we just put a label saying it is COVID-affected family with their permission. With their permission. And immediately they also liked it, and then we found that the neighbors were keeping food parcels in near the door and then calling them and saying, you know, where we have left here something, since they were unable to come. So we gave also instructions if they have only 1 washroom and 2 bedrooms, where the 5 or 6 in the family, as to how they could manage this. And that was an example where we came out of the box, out of the normal system, and we treated 141,001 death, and that was, I was imagining at that point in time, we had only 90,000 beds in the country. So if all walked into the hospitals, you would have had a real pandemic. So these are something that we can share. That's something that we shared. And in fact, we had another experience where we placed the order with India, with your government, with the serum company, 4.5 million, and the silver was unable to provide it. And then we had to do a makeshift arrangements during that time. So as far as our health is concerned and the regional connection, the connectivity and sharing things, I think is, as I've told you, there are three things. We'll have to look at those as well as the how, one could share it. Equality has to be maintained, right? So all that has to be maintained. And I would also say that India in the region has become a giant in the IT, right? And intelligence, artificial intelligence. I think that is something that we can share it and work, reduce a lot of paperwork, and as my colleague said from here, where you can have connectivity, you can have all these, whatever the prescriptions tied up into one system. Thank you very much, and I'll take this opportunity to thank the Government of India for their great hospitality, and thank you very much.
Thank you very much. In fact, I must tell you here, that Sri Lanka has one of the best, IMR and MMR, aspect. They are really good at that. But one aspect which he mentioned was the home health care. In fact, we are now telling, besides the new company which are coming to provide home health, we are telling our hospitals now to open a vertical, because a 100-bed hospital can create 500 extra bed through the home health. Only thing is you need a trained, workforce which can really do this job. So I think this is a wonderful sharing of your experience. I think now with that, we go to some opinion from our delegates, and I think one I would like to invite our NABH colleague. Very briefly, please tell us how you are able to provide the accredited services to the neighboring countries, and can you also help in setting up of the accreditation board? Very briefly, please tell us.
Yes, sir. So good afternoon, everybody. First of all, I thank the chair and Gyani sir for this opportunity. I am Dr. Kumudita Talwar. I am representing National Accreditation Board for Hospitals and Healthcare Providers in India. So that is briefly as NABH. We already have a touch point of approximately 18,000 organizations across India and also in ASEAN and SAARC countries where we have accredited them. Countries like Philippines, countries like Nepal, and also Bangladesh. We offer NABH International as one of our wings. Our standards, which are accredited by ISQA, that's the International Society for Quality in Accreditations. We are accredited with them. We give you global best standards, which are accredited, and we offer it through NABH International. So we give trainings in that. We give you program on implementations in that. So that's how briefly we can touch upon the ASEAN and the SAARC countries and get these standards across India, outside India also. Another aspect that we have with us is the empanelment of medical value travel facilitators. We also have that program where we give standardization, which is very easy to comply with. It's a checklist based. That's also a standard. So that's a very brief what I want to talk about NABH and how we can collaborate with you, come to your land, give you trainings on that and collaborate and help you set up and give you best practices what we do over here. Thank you so much. Thank you, sir.
Request had come from Pristine Care. This model what they are trying, because in India also, there are some hospitals where there is acute shortage of the beds. But then there are certain places where the beds are freely available. Similarly, so what they do actually, they share the expert doctor from one place to another place using their facility. Briefly, please tell us what is this best practice which other our partner country can adopt. Yes, please.
Hi, my name is Dr. Vaibhav Kapoor and I'm the co-founder of Pristine Care. So what we do in India is Pristine has its own clinics. So we don't build our own hospitals. What we've done is currently we have close to 250 clinics across India. And all the doctors, these are all specialist surgeons, gynecologists, plastic surgeons. They sit in the clinics every day. So they are full-time employed with Pristine. They sit in the clinics all the patients are seen by the doctors in the clinic, and the surgeries happen in our partner hospital. So we believe every hospital has some spare capacity which they want to utilize. So instead of building our own setups, we are trying to utilize the existing hospitals' capacity, filling their beds, utilizing their infrastructure as well, so that the benefits can be passed on to the patient as well as to the hospital. Now, sir, coming to international, we've recently started our operations in Bangladesh, and pretty much on the same thing. Like Abhishek sir mentioned, for tertiary care diseases, of course, the patients would want to travel to India. But a lot of secondary care surgeries, happen in their home country as well. So the challenges which we have faced, when we started Bangladeshi operations were, one, Indian doctors are still not allowed to operate there, right? So that was the first thing which we realized, and that although probably world over our degrees are recognized, right? But probably in Bangladesh we still can't operate. So what we did, we hired doctors in Bangladesh, got them to India, trained them for a week or so, and then they went back and started doing those surgeries. So sir mentioned on exchange program, right? So we did a small pilot on that exchange program where we got the doctors here and trained them. So I think this can be done in a very process based manner. Second issue what we faced was, now of course we can't take our doctors there, but even the non-medical staff, the back-end teams, which we had placed from India there, they get visa only for 30 days. So every 30 days they have to come back to India, reapply for the visa and go back again. So probably an extended business visa, if can be given for in certain situations, probably for a 6-month or a 9-month period, will really be helpful, because otherwise almost 4 days every month go just in traveling plus the cost and everything. So that was the first part. Second thing was where under Heal by India we tried to do a camp internationally. Now, what we, of course, we went to that country, we did almost 30 odd surgeries in that 7 days. There, of course, Indian doctors were allowed, but the issue was that the visa the surgical doctors got was for 1 month. So next time they had to go for a follow-up, again the visa had to be applied again for the doctors, and it almost takes 45 days to 60 days to just go through that process. So if an extended visa can be given even to doctors, right, that okay, because they'll have to go for first for operating, second time they'll probably go for seeing new patients and follow-up of other patients. So if that visa can be extended for a good 6-8 months, even for the doctors, that becomes really helpful. Yeah.
Luckily, the session chair is from the Ministry of External Affairs. He has taken note of it. Now, may I invite first, the delegates who are from the foreign countries. Please, anyone from foreign country want to make the point? Anyone from Nepal?
I have few remarks actually. I'm Dr. Anil Bikram Kargi. I'm the president of Nepal Medical Association. So what we have seen is, like, we have patients who come to India, especially in oncology, cardiology and things like that. There are few issues that makes it difficult as a doctor for us. Is one part what His Excellency said is the follow-up part. The second thing is what we have as experience is the capacity building on our part is not taken care very well. There will be like CMEs and all that, but no hands-on training. And we in fact had tried when our Honorable Prime Minister had come to Nepal for an equivalent in degree. Like a lot of us study in India and go or from here go there. So that would like ease the problem what they said. And another issue is like what we I think should develop is a common background on medical research and medical value tourism. Like our disease pattern are same, our lifestyles are same. So if we have a common medical research, multicentric research and all, so that would lead to a ownership to all health sectors. Not only in terms of money, but also in terms of disease pattern and where we should focus for equity in healthcare. And especially when we advocate for preventive measures, because that is, I think, where we also as health care, we are lacking. And if we can develop this sort of pattern, so we can enhance the public health system in the similar way. And third thing is the access to what achievement India has made in healthcare is not very much open to the third world countries, third world neighbors, like we are just beside. And access to healthcare from people who can pay from the pocket to India is there. But for the unaccessible, it is still not there. But they can make access in India. So I think we should formulate policies on that also. Thank you.
Dr. Karanjekar, you would like to share something with your global experience? Oh, first, okay, please, yeah.
Good afternoon, everyone. I'm from Maldives, and I'm the owner of the Edike Hospital in Maldives. Edike Hospital, I started with a small clinic 36 years before, with an Indian doctor, one doctor. Today, I have more than 400 Indian professionals employed there.
Wow, great.
And the hospital is one of the largest private healthcare setup. And today, we do tertiary care services with healthcare services, which is open heart surgery and endovascular surgery. And we even do TAVI and all this stuff. So, my point here, what I'm going to say is to the nature of the geography of the Maldives, as Dr. Shah said, Maldives, 1,192 islands when it is there. It's a logistical nightmare for the transport of it. When a patient is there to bring them, during COVID time, it was been experienced. But it also came to an advantage for us during COVID. The word isolation, we really feel that it is good because we were isolated in each and every island, and that helps us to open our borders and to make some benefits from the tourism side. What I would say, I'm trying to here to point out is, because of the geographical logistical situation, every patient who is coming to India is not necessarily coming because the services is not available. Malé city, as those who have visited Malé city is a very congested place, and it is one of the expensive cities. So for an islander, if they come and want to stay there, it is more costly. So they will ask, Azam is here, he is the head of our National Social Protection Agency. So they will ask their assistant for them to go abroad, so which means it is more affordable and for them, and also the services is definitely, it is much more. We have grown as a system with the help of India, and together we have got tremendous assistance. I think capacity building, which we are talking today here, is in one area which we should be focusing. We are also nowadays we are utilizing the services of the technology. For instance, we have 2 MRI and radiology department, 3 Tesla and 1.5 Tesla. With the today's trend, all our radiology is going to a company in Delhi, Telerad.
Yeah.
And we are paying close to $500,000 for them. Okay. So this, should we do it in Malé by employing more Indian doctors? No, this is more cost effective for us because it's coming very fast. We are getting the reports, they have a system, and these are the things which we can use it. The medicaments wise, there is an issue, I would say here. Our regulators sometimes think the Western medicines, Mr. Shah is here, is the best. I don't think so, because India has proven that they are the pharmacy of the world. In the COVID situation, they have proven India is the heart of the world. They have proven that. Everybody was been looking at, waiting for the vaccines to come. And we really thankful for delivering. As a first country, we got the COVID vaccine to Maldives. We thank all the Indian people and the Indian government for assisting us. So the Indian medicine, of course, there are regulatory-wise some issues which we know in the cough syrups case in Africa and Indonesia. So, but for there are a lot of generics good, which you mentioned, Cipla and Sun Pharma. we have to see how best we can lower down the cost, and this can come into our system, because it is equally good to medicines. The person who is coming for the treatment in India, they are happy with the Indian medicine. When we dispense it, they expect an imported Western medicine. So it is not like that, I think so. At the same time, I would say that today what you have launched, that one-stop digital platform, this will have a better access for our people to know that India has all the solution at a more affordable price, rather than going to other South Asian countries. India has a better solution and more friendly relation we do have. So I think with that platform we would be able to source the right kind of treatment at right price, where we can source it. I think that platform we can use it. We look forward of growing more together with your assistance, and at the same time we need your support to build our capacity. Thank you very much, Vicky, and every one of you for inviting us and learning more knowledge and how the system is working, and thank you very much once again.
Thank you. Any other foreign delegate? You are from? Okay, very nice.
I'm from Bangladesh, sir.
Yeah.
So thank you for giving me a chance to speak in front of you. And first I'd like to thank Dr. Vivek for opening a pilot project in Bangladesh, Christian Care, which is actually required in Bangladesh because maximum number of foreign patients comes to India from Bangladesh nowadays. And whenever a patient comes to India to get the treatment, definitely we need to have a proper follow-up over there in their own country. So that the idea is very good. But I just wanted to tell you something that I think misses. Yes, that is true that Indian doctors are not supposed to go Bangladesh for the surgery, but they can do as a trainer. As a trainer, they can do the surgery over there through the government hospitals. And even though lots of Tamilians doctor used to go to there for as a trainer to train our local doctor and do the surgery over there. That is a ruse over there. Another thing is regarding the paramedics and other staffs. I just started working with NSDC. That NSDC can provide the certificate to the peoples in abroad, and we can bring the trainer from here, India, to in my country to train our staff where we need a permission from BIDA. In Bangladesh government, there have authority called BIDA. Through the permission of BIDA, we can train our staff over there through the expertise from India. Because as a good connectivity and relationship, there are a lot of options, but just because of not much activities in, so that I don't, this information missed, so that I just want to tell. And I am also started myself from the medical tourism in 2015. After that, I started few hospitals in Bangladesh just to take care of those patients who come to Bangladesh, India to get a treatment, and they need to have a follow-up in their own country. So that we have built and we started with few hospitals in Tamil Nadu. Our doctor come here to get the train, and whenever a patient come to Tamil Nadu and go back to the Bangladesh, those doctors are the one who follow up. Even I have a good experience in COVID, as I am running a hospital with the ICU. So in that time, I had a case in my ICU is a pregnant lady with 65% blockage. And you know, whenever the starting of the COVID, lots of doctors are not much good knowledge how to handle those kind of cases. So I use the technology and I bring a few doctors conference with my doctors and Indian doctors. So there are seven doctors give a conference and give some medicine, and the patient got successfully recovered. So sir, whenever lots of patients are used to not be able to travel, you know, because some emergencies are there, they cannot be travel to here. So we can use the technology, but I prefer whenever we will use the technology by the video conference, there should be a local doctor to assist. Otherwise, patients are not supposed to understand what is the things. And as I am got an opportunity to speak in front of you, I just want to give few points we needed to be recovered. Lots of patients are used to travel from Bangladesh to India because of the transparent comfortableness, because 1 hour journey we can come through by train also. But the problem is whenever a patient comes through the train to Bangladesh to India, as a patient they might need an ambulance service. So in the Kolkata, that Kolkata station don't have that ambulance facilities. And also in Chennai, whenever they travel from Kolkata to Chennai, there are some certain things we need to operate by support of the government of India. If a patient comes to the airport or sent, so the ambulance service and that thing has to be done over there. Thank you, sir. Thank you for giving me a chance, sir. Assalamu alaikum.
You wanted your allied healthcare people to be trained in Bangladesh, you said?
Yes, sir.
Allied healthcare people you want to be trained in Bangladesh?
Yes, sir. What we are doing, we bring the doctor from Bangladesh to Tamil Nadu, we train them and we bring them. Even though senior doctors can go there in a government hospital to train them. That is allowed.
Two more comments, okay? Yes, please. Short comment, yeah.
Yeah, thank you so much. I'm Azam from Asanda in the Maldives, and we are one of the organizations who have experienced and have good relations with working with Indian hospitals as well as Indian service providers, and I'm really grateful for that, and I concur on the experiences that Dr. Shah as well as Mr. Nashid has shared. I just wanted to highlight one key fact that thinking for the future, going ahead, I think one of the things that we are missing right now, we are already getting treatment, we are doing clinically well, we are getting to where we need to treat people. However, I think as a small country, what we are facing right now is that most of our issues are stemming out of lifestyle issues, and lifestyle diseases are the core issues that we have. And I think some of these preventive mechanisms for the NCDs don't necessarily come from health as traditional health aspect or public health aspect, but rather stems from policies, stems from how a country deals with a lot of issues that they have around that around how food as well as trade as well as behavior as well as all these things are facilitated within that nation. So I think a lot of policy support as well as governance as well as regulatory support beyond the purely health sector is, I think, something that we would really be grateful or be useful to have in terms of going to the future, because helping people deal with those issues, helping people to design their lives around ways that can prevent them from going into these NCDs. I think there would be definitely learning lessons learned from many other countries around the world as well, and I think that would be really something that we could benefit from India as well. Thank you so much. Yeah.
One last comment, anyone? Okay.
Thank you very much. I am Dr. Rajendra Prasad Baral. I am one of the senior most oncologists of Nepal.
Oh.
And it's my pleasure to say to you that I am past chairman of SAARC Federation of Oncologists, comprising all 8 SAARC countries.
Okay.
Frankly speaking, as you said, Maldives, many islands, Nepal is a landlocked country, 3 side India, 1 side China. Just coming to Your Excellency, 2001 SAARC Federation of Oncologists was established. Till then, every year we do conference and never from Maldives. We tried many times. I have been twice to bring the oncologists from Maldives. So December again we are having conference. We want representation from Maldives. As my friend Dr. Anil, as a chairman of Nepal Medical Association, has already mentioned, Nepal and India, 2 countries, bhai. For your kind information, no need of passport to go Nepal for Indians. We don't also need any passport or visa to come to Nepal, India. So this is an open border country. So many of our patients, I studied in India, my graduation, post-graduation, Tata Memorial Hospital from India. So I'm educated in India. So still till today's date, we are very successful in our treatment in Nepal. But still, many of the patients who want good quality of treatment, who can afford, they come to India. In every centers, outside if we go, Ajay is there, my friend from Apollo, everybody, in Nepal, in patient bhejo yaar, patient bhejo yaar. That's good. But our humble request to government, please don't treat us as a foreigner. We are also Indian. So charge us in Indian currency, not as a foreigner. Number one request. And as mentioned by our friend, chemotherapy drugs, maximum are produced in India and we deliver the treatment. Many of the oncologists here, अरे 2 cycle ले लिया, 3 cycle, यहाँ से दवा ले जाओ. That we don't accept because some drugs are more cheaper in India, in Nepal than India. So this mutual collaboration tuning is very important, and we are going to raise this valid question in our upcoming conference. Thank you very much.
Anyway, I think what you said, there is nobody foreigner as far as the health is concerned. That's why we have kept one earth, one health. Now, I think with that now I'll request the session chair to close the session. I have made the points. I'll submit the report later on, but let him conclude the session.
Thank you, Dr. Gyani, for moderating this very insightful session. We have heard the experts, we have heard the authorities. I think one aspect we will all agree is that we are more knowledgeable about, the issues in this sector, especially how we can further collaborate. Dr. Shah was very kind in, describing the issues, and he was also very candid in expressing that, finally, any country would, of course, look forward to having their own capacity. And like we have always stood with our brothers and sisters in Maldives, the aspect of capacity building, which was expressed by His Excellency, the Honorable Minister, and members of the industry also. This is one area where, we can further collaborate, and there are institutes and there are programs of Government of India where, capacity building in the field of medicine and medical sciences can be done, which of course in the long term will enable you to have your own doctors and your own hospitals. His Excellency, the Health Minister of Sri Lanka, spoke about several issues, and he also, the point when he mentioned about the home management which was developed by Sri Lanka during the COVID pandemic, reiterates or stresses the fact that we have so much to learn from each other. And there is not one country which can say that we may be referred to as the pharmacy of the world, but we can learn so much from each other, and that is just the case in point. And he very rightly mentioned, His Excellency the Honorable Health Minister, that alone we are like drops and together we are like ocean. So I think the collaboration we always had within the SAARC countries and within the ASEAN India, it's always strengthened, and it adds new dimension to our collaboration. Of course, the new ideas about IT and artificial intelligence has also been noted down. Pristine Care has been doing good work, and we applaud Pristine Care for the innovative steps that they have taken. I am sure there are many other hospitals and institutions and organizations in India and other SAARC countries which have been following innovative practices. When they have a clinic, I mean, how innovative it is that they have a clinic, but they use the facilities of other hospitals because they always have some space to cater for that. And they have, I think, around 250 such clinics in variety of fields, and they have done good work in Bangladesh, which is of course another very friendly country and a great partner. And the point about the extended visa, I think it came from your side, and few other corners I will discuss with the the concerned territorial division in the Ministry of External Affairs. And the point is well taken, and it makes a lot of sense that one should, if there is a requirement to come time and again, so extended visa would be helpful. So I will of course take it up with the concerned authorities. Regarding also the the collaboration that you mentioned in Maldives with the Ekta group about when you started with one and then you now have 400 doctors. Many of them are Indians, I believe. So I mean, Indian professional only. So of course in the future you will, I'm sure you will have many more Maldivian doctors also. And the training part that our colleague from Bangladesh mentioned, that while probably it is not possible for Indian surgeons to operate there, but they can go to government hospitals and do the training. Training of the trainers, as they say, of the doctors. Of course, doctors are already qualified, so they add some more dimensions to that.
On the procedures.
Procedures. And language aspect also you mentioned, but luckily, I think in Nepal, people understand Hindi. We don't understand much of Nepali, but Hindi is fine, and a lot of people in Bangladesh.
Bangladesh, sir, everyone understand Hindi very well, even the bacha.
Yeah, so I think we can, those who are not from Bengal also can manage a bit of Bengali. So I think language should not be a barrier when with our countries. And the point that Dr. Rajender of a very senior oncologist of Nepal mentioned, I think it's very relevant that when you have open borders, so why treat each other as foreigners? So I think big hospitals are represented here. I don't think Ministry of External Affairs can educate on that, but hospitals are there, and the healthcare professionals are here. So that is a point that you need to consider. And also about mutual collaborations that he mentioned, that there are certain very specialized treatments which probably might be available in India. So people like to come and get those treatments. So that also has to be at affordable price. So I think the general sense that we get is one, of course, of facilitation, that is ease of movement of patients and doctors, both. To all, each other's country, doctors from India going there, or, patients coming in, and vice versa, as the case may be. And also, the other issue, that includes the issue of extended visa and visa. The second issue which clearly comes out is capacity building. And I think that is something that we need to keep as a central aspect when we look at collaboration. Because till the time we have, enhanced capacities, then there would always be, one-way inflow. So to have, a robust exchange, we have to, collaborate in capacity building. And I think India, I can speak for India, we have a very neighborhood first policy, that is well established. And, I don't want to talk about what we have done for each other, because you don't need to talk about it. It's like one family. So within the families, we don't talk about that. And we will be always, within, of course, our capacity, try to be the first responders whenever there is a need. And that point needs to be stressed again. And third, of course, is that, innovation and, sharing of ideas, technologies is something that is an ongoing process. And today's, session was, for me at least, being from outside the medical fraternity, a journalist, it was an eye-opener. I take back a lot of valid points from His Excellency, the Honorable Ministers, from the experts, from the industry. What we should incorporate when we are, formulating policies. So we look forward to work closely with the industry. Thank once again FICCI for organizing a wonderful session, a very important and a useful session, and Dr. Gyani for moderating it. Thank you very much.
Thank you so much, Mr. Singh and Dr. Gyani and esteemed panelists and participants. Thank you once again. We'll now have in a while the session on insurance portability in this room. The other session on patient journey is going on right now in Seminar Hall 1, which will be followed by the session on innovation and technology. Thank you.
હા એ તો ખ્યાલ જ મને એટલે ડીલે આવે છે ને થોડું. હલો માઇક ચેક 1 2 3 તો ડીલે આવે ને આનું.
अब आप वाला ऑन करो, मैं नहीं देखूंगा। अब आप वाला ऑन करोगे ना तो वो अटक जाएगा, वो यही लपड़ा हो रहा है। नहीं, यहाँ तो हम दोनों है पास पास,
બે જણા ચાલુ રાખીને
यहाँ तो हम दोनों पास पास हैं,
પાસ પાસ એ બરાબર
ये तो है। अगर आप उसको ऑन करो, देखो आप जाओगे लेकिन यहाँ आपने ऑन करा, इसने आपको कैच कर लिया, बट बॉल में रहा हूँ तो आप ही को कैच करेगा, चाहे आपने ऑन करके छोड़ रखा हो। और ये ऑफ करते यहाँ गया, ये तो स्टिकर फोकस कैमरा है
Okay, got it. So
ऑफ करते
Requesting everyone to kindly be seated. We'll start the session soon. Please be seated. Thank you. Kindly be seated. We're starting our next session here. The session title is Facilitating Medical Value Travel Through Insurance Portability Across Borders. The session chair is Mrs. Yagna Priya Bharat from IRDAI, and session will be moderated by Mr. Lalit Mistry, the co-head and health sector lead for KPMG. Lalit, over to you. Thank you.
Good evening to all our esteemed dignitaries and delegates. A warm welcome to our session chair, Yagna Priya Bharat, and all our industry experts from different parts of the country and also from the Africa representing and being part of this session. Today, as a part of this session, which is named as Facilitating a Medical Value Travel Through Insurance Portability Across Borders, we will be discussing about the various aspects about how the medical tourism or medical value travel has fostered in the last few years, increasingly providing an opportunity for cross-border providing of the healthcare services, leveraging of the healthcare resources and infrastructure. But above all, it also presents to us some of the interesting challenges that we have to address, including the insurance portability and how do we ensure the continuum of care, and also that insurance and the minimal efforts and the challenges are faced by the patients when they travel for the medical value travel. And for this, today we have an expert from IRDA, Yagna Priya ma'am. I'll hand it over to her to open up this session and do a special address for this session before we get into a detailed discussions on this topic. Ma'am, over to you.
Thank you, Mr. Lalit, and good evening to all of you, to all the dignitaries here, and ladies and gentlemen. Well, by way of introduction, let me try to mention a few basic things about insurance. Insurance is basically a financial protection mechanism, and health insurance is a financial protection mechanism for healthcare expenses. Largely, insurance covers hospitalization expenses, but there is an element of outpatient expenses that is also covered, and that is gaining traction now. Insurance basically, and in this context health insurance, would basically provide accessibility and affordability to healthcare. And I think that makes a great impact for medical value tourism, because it's not just about availability of quality services that India has, but also there's a mechanism that can actually enable somebody to have access to those services. And when we talk about portability of insurance across borders, we basically mean the acceptance and the validity of insurance policy of one country in another country. So in our context, we have two situations. One, we have travelers coming into India for medical treatment. We also have instances, and of course that is coming down now as I hear and see, people may want to travel abroad to take certain treatment. There are certain instances that still do happen. First, let me talk about people who go out of the country. There are two kinds of insurance covers that are available. For people who generally go as a tourist to visit a country, the overseas medical claim policy or product, it's called by various names by various insurers, would cover any kind of emergency expenses that would arise when one is visiting a country and one suddenly falls sick. But we are today talking about medical value tourism, where we are looking at traveling to another country to actually take treatment. So in that context, in India, we do have health insurance products. Though all the health insurance products in the market do not cover this situation, there are products which not only cover one against expenses incurred in India, but they also cover expenses incurred abroad. So if I take a policy that has a clause that says that I can take treatment abroad, I'm basically talking about treatment cover that can be provided for medical value tourism. The other scenario is when people travel to India, and in the context of MVT, I would like to mention that almost 20 years ago, third-party administrators were set up in India through the regulations. These are basically extended arms of insurance companies, and they basically assist in servicing claims. So not only are they permitted to service claims arising out of health insurance products in India, but also foreign policies. If people have taken insurance covers abroad and they are coming to India, those policies can also be serviced. This is something which has been permitted right from 2016. But when I look at the data, I find there's hardly any claim that is serviced in India under a foreign insurance cover. So basically that means that the products which are issued by foreign insurers where their policyholders are traveling to India probably do not cover, medical expenditure incurred in India. And I think that is what we are here to discuss today, because there is ample opportunity and a need, in fact, for other countries to consider covering expenditure incurred in India towards health under their products. India has the required infrastructure to service. In fact, the insurance industry has a network of hospitals, basically providers, and I can find many of them seated here. All of you are part of the network providers of insurance companies and third-party administrators. You have the infrastructure. We have the technology and the interfacing. In fact, so many initiatives have been taken at the Government of India level, the Ministry of Health and Family Welfare, in particular by the National Health Authority. You have the National Health Claims Exchange, which is a technology platform. In fact, I'm glad to say that all the 29 companies which offer health insurance in India, the general insurers and the standalone health insurers, are already onboarding themselves to the platform. And once the hospitals also come on board, then everything can happen, real time through the platform. It will make things cheaper for the policyholder. It will also bring in transparency and speed. So the point I'm making is, with this kind of infrastructure available in India and with a system already in place where third-party administrators can service foreign insurance policies, I think there is a missed opportunity. And this is what I would like to really, throw open to the house here. And we should look at how we can leverage, the infrastructure and the facilities available in India. And the important point to note here is, by doing this, it's not about insurance for the sake of the insurance industry. It's about health insurance is about giving access and making it affordable for a person to get quality health care. So also I'd like to mention that today let's look at what are the challenges. We'd like to understand from you what are the challenges and why are we not able to do this today. And let's look at the opportunities and let's see how we can leverage on that. So with these introductory remarks, I'd like to hand back to Mr. Lalit.
Now I will open the forum for each one of you. The question is, as Madam said, what are the key issues and challenges that are preventing us from driving the insurance portability in India across various nations where the patient travel for the the treatments? What are the key challenges that we have? If I could open this forum, feel free to share your thoughts around it before we go into some of the measures that could be taken from the government side, from the industry side, and others. Yeah. So forum is open. Yes, sir.
So very good evening, ma'am, and Mr. Lalit and the house here. It's a very, very important issue as insurance goes with the medical value travel. Of course, to leverage the medical value travel and the infrastructure availability, we need to, I think, really take up tie-ups in a very serious manner with African countries and other countries which are currently seeking healthcare services. Like, for example, companies like VIII, they are often sending patients into India, but they are doing it as an international policy level player. that role can be played, by our insurance companies, and also there can be tie-ups facilitated by IDA, wherein these tie-ups can help, giving better access to the patient's coverage into our hospitals. These companies are very, very dedicatedly working. I've just cited one example of Africa. There are, today the Look West policy is there. For example, we have incorporated our office in London currently, and our first portfolio was that to tie up with BAPIO, with the NHS, to get that system into play. And because though there is a huge wait list, but to cover them again in India, that kind of tie-ups directly through the governmental insurance companies and other private players here is very important. What we can do, I feel, to leverage this is that GIPSAs are there. We could straight away give the responsibility and play through them. That could ease out the issues to quite an extent and open up the system for medical value travel, and there could be a very big boost from India. 21% is the growth rate per annum in India, but I think with this we can really go up to around 48% if this opens up. This is a major, major obstacle, of course, but we really need to work towards it jointly, collectively, and to make it happen. We can take up, cases, parameters which are adopted by the US insurance companies, how they are doing it. When an Indian patient, for example, traveling to US, we are taken into emergency, everything is catered to immediately, and later on also the complete, tie-up or the reimbursements take place. The similar kind of situation can be tied up through the GIPSAs here. And that's how we can, get more inflow rather than outflow. This is one of my thoughts. I would also like my other colleagues to comment, and I would like to carry on with that.
Yeah, please.
Thank you very much. My name is Matweza Lole. I'm from Zimbabwe. Speaking of challenges when it comes to portability, because portability refers to, a situation where if one is insured by medical aid or medical insurance A, they can move across to medical insurance B with their benefits. If they were having a savings account, is still there, waiting period waiver is still there. And if they travel to countries like India for treatment, it means they don't lose anything. However, speaking of challenges, I think most medical insurance companies have not really been able to come out to do proper product development that enables that to happen. For example, health savings accounts. It's one product which health insurance companies can actually come up with. It's widely practiced in the US, for example. In this setup, it's more of a triple tax advantaged setup where the contributions to the HSA, they are not taxed. The monies can be invested and they can grow. And when one withdraws that money, as long as they use it for travel due to treatment, it's not taxed. So I think one of the best ways to address that challenge is to have product development, especially in countries where it's not there, because India is ready for that. So, but meanwhile, from where I come from, and Zim, when we send our members to India, we are doing the prepayments to encourage the portability aspect part of it, or sometimes we do the transfer, TTS, telegraphic transfers, so that members are assisted. So I think from a challenging perspective, if insurance companies can actually develop products and find ways around it, then portability can be a possibility. Thank you.
Okay, I think my name is Nancy from Ghana. As he rightly said, it's all in the product design. Because currently, if you want to do any medical travel, you're technically on your own. the insurance may not cover it. And even when they have to cover it, like you said, transfer charges and all that, ends up inflating the price which you would pay in India or anywhere else. But we have cases where the cost of treatment and the quality of treatment is better in India than in your home country. But this is a case where we restrict the insurance product to the home country. And if you want to take it across border, then you must purchase necessarily an international health insurance, which is quite expensive. So it's all in the product design. If you are able to design product, that would make it possible for you to have a Ghanaian or an African insurance, but still have access to care in India. And we get to deal with all the taxes, like transfer charges and all those other things. If you're able to deal with that, that might be at the government level, or if you have a tie-up with that, there's some kind of, it comes back to portability, but if there's a portal where payments can be made, as in I'm in Ghana, I can still pay the money in Ghanaian cedis, but it's going to reflect in, what's it, rupees, right? It's going to reflect in rupees here without me necessarily have to going through the bureaucratic thing of actually getting the money, transferring it in USD or in rupees to India. Then it becomes really portable. Again, when it comes to portability, the other challenge you'd have is coding, medical coding. You may have one name in Ghana, another name in India, and sometimes it's not that easy. So that even the billing is problematic. But if you have a proper tie-up with the India, or you empanel Indian hospitals purposely for the product you're making, so you have an empanel, a group of hospitals in India for the MVT part of your product, then you know who you are dealing with. You agree on tariffs, you agree on coding. Yes, there's ICD 11, 10, whatever you want, but then we all call things differently. But until you're able to call everything the same thing, then your partner can understand exactly what you're talking about. Of course, you need technology to do all this. So once you're able to get across that, you're able to improve the insurance portability we're talking about. So yes, it is there, but I think the challenges are not major challenges. They can easily be overcome in the product design and in the policy direction, and this could improve things greatly. Thank you.
I totally agree with her. In fact, country-wise also it can differ. Some countries are 100% taking the security and the social responsibility. For example, Maldives, the ASEAN+ is the organization which is sending all the patients to India currently, and they are being cured. And as I mentioned prior, VIII is not restricted to one African country. It is into a couple of them. So acceptance is happening. All we need to do is to open up, as she rightly said, to the product, a special product which could be internationally acceptable. And plus at the same time, we can come up with international sales if that is possible. Currently that is restricted.
Any other point?
Another way I am trying to put in front of it, Dr. Atul is sitting here. So, you know, when we started NABH, so people who were coming from other countries, they were ready to extend the insurance cover for India, but they wanted that hospital should have JCI, Joint Commission. So, you know, we took up the matter, and at least 2 insurance companies, they accepted that if you have NABH accreditation, we will extend the cover. But vice versa was not happening, because Indian insurance company covering expenses for USA in the premium was not possible. But at least I can say that people are coming to India, the NABH also can play a role, and I'm sure you must have done it, that they can talk to the insurance company that if we are accrediting, that liability to a great extent gets covered. So this is, I think, another point of view I want to put.
Yeah, thank you, sir. I think that's a very valid point, sir. We have time and again reached out to IRDA, GIC and GIPSA also for creating products which enable cross-border policy support. I think there's lots of positivity in the current environment, and going forward we hope to get at least some products which are valid, and I'm sure there are already some, and many companies are already working on it also.
Dr. Atul, do you also think the upcoming health insurance claim exchange could further be extended across the borders, maybe in the coming times, and you see that could be leverage for medical value travel and the insurance portability?
Absolutely. I think insurance health exchange is a wonderful idea. Government has gone ahead and adopted it. NHA is already acting on it. And in the private domain also, I think lots of work is already underway. So going forward, there is no rational reason that why it should not be expanded beyond the borders. Because that ensures objectivity, transparency, and it eliminates all kinds of delays and possibly fraud also. So that's the way to go in future.
Great. Dr. Anupam is here. Dr. Anupam, from the hospital perspective, what are the challenges that you see mainly between the two countries, where the medical travel is happening? What kind of challenges and what kind of measures that could be taken both at a hospital level and at a policy level?
Thank you so much, Lalit and Ms. Bharat for organizing this session. I think one of the keys, when patients or organizations decide to move patients from one country to another, they obviously look at quality, they look at cost, they look at ease of travel, they look at multiple factors. But if you have comparable sort of quality and ease for travel, then how you actually pay becomes the determining factor. And because India values, the India value proposition of high quality, competitive cost, we've been able to make inroads. But let us recognize the fact that we have a long way to go. Because if we look at the global, the market, for want of a better term, and if we look at the positioning, we still have an opportunity to go several notches up. And I think what we are discussing here is really going to make a big difference, because patients have numerous problems in transferring money, in actually getting reimbursement locally. I think we are so behind the financial services, and there's really no reason for us to be decades behind. None of us have a problem ordering a book just now while sitting here, and we'll get a notification in 1 minute. Try doing this in healthcare, and you'll realize the number of loops that you have to go through. So I think there's an opportunity for us to be able to ease the way we actually operate, and I think we might have complicated it more than it really needs to be.
Siddharth, you want to add up some of the points from your side?
No, I think the point I would like to make is it's important to look from the patient convenience perspective. But it's also very important to look at from a hospital's perspective. See, a patient, there are countries where US dollars or foreign exchanges are hard to get. So for a patient to come for a critical ailment with a lot of cash, the way it is converted in India, the safety aspects of it, the hospital being able to accept a certain limit of cash, then look at FEMA guidelines, being able to send it back to the patient. It is, as Dr. Anupam says, both from a hospital perspective and from a patient perspective, hard. Many of the African countries, Indian banks operate, for example. Is the real conversion from local currency, does it have to go through US dollars, or could it be direct for medical travel? With some safeguards in place, but also bypassing some of the very stringent aspects of FEMA. Those regulatory aspects have to be looked in, and there's a lot of patients who ultimately fall through, and there's a lot of conversion losses that also happens. And if a patient comes to India, suddenly they come forward with a certain amount of money, they need further money back. There is nothing like a wallet where the money can be transferred easily. Insurance portability, I think, is a next level. This is very basic, and today this is a challenge for many of the hospitals. I just wanted to add that point. Thank you.
I think my next question would be that, is there also an important need for us to bring the efforts from the government, from the industry, and from also the patient side all together, because there is no convergence here. the governments and the hospital players do make their efforts at their individual level. Most of these efforts are more at a standalone basis, but I think there is a need for a larger convergence, because some of the issues that we are addressing cannot be dealt by an individual hospital player and insurance player by themselves. You might have a tie-up here and there, a joint venture, understanding, collaboration, and so on. But if the larger changes has to happen, it has to be a collaborative efforts from the industry, from the government, and the patient forums coming together. What's your point of view? What is required to be done in this front? Is it something that is possible, too ambitious to happen? We have seen that happening in other places. You have a SIM card, you can travel across the world. There's portability there. You have Ayushman Bharat, when it was designed in India. This was one of the reasons that some of the states didn't have those facilities. They could go to any state, get their treatment, irrespective of public or private sector. So that's happening in India. I don't see that. And from the COVID, we realized that these borders are just for the name. When patient require healthcare or life-threatening situation arise, these all borders disappear, and we start helping, and we need to support. So, do you think that larger perspective in terms of convergence is required from all these things? Anyone who has any point of view, anything from your side, please feel free to share.
Good evening, everyone. I think IRDA can play a crucial role when we are talking about especially insurance. IRDA can take a lead and have a huge infrastructure when they can associate, and hospitals get the safety of the money and these inconveniences which we talk about, standalone hospitals doing some tie-ups with the international insurance companies. IRDA can be a best solution that can help to ease this process.
Yes.
Yeah.
You can speak.
Yeah. Mr. Mistry, I just want to. Yeah, good evening. My name is Sanjay Sharma, and I'm CEO and MD of an insurance company based in Tanzania. It's a PSU representation, all consortium of 6 companies, including GIC, which is based in Kenya, and then this is a subsidiary of Canada unit in Tanzania. So it's a PSU representation where management control is within the hand of the PSU. Our colleagues are on deputation here for a fixed term. Okay. So I would like to bring to the whole house, what is the current status of the international market on this. So currently there are international products, which responds to treatment in India. But those products are niche, high-end products, So they're little expensive, beyond reach of the masses, So that's the limitations on that, So there is a big and large protection gap existing because of the price line, high price line. Now, when we talk of portability, in Indian market, we are offering overseas travel insurance, That is offered to the Indian nationals, who are resident of India. If they travel overseas, Here it's a different requirement, This product is, the consumer are foreigners, primarily, or maybe NRI, So currently there is a need where Indian industry, which as Madam mentioned, is missing the opportunity. So the opportunity is missed at our local level, So local industry has to come up with some products, which will cover foreigners, NRIs and others, who will in turn get automatic, the policy will respond treatment in India, since it is being established, it is being, developed here, it is being, So the premium will come in the local, it will be an influx of foreign exchange, so there will not be any regulatory issues on the Foreign Exchange Act also. So, and when it's the claims management also, this again a revenue for the Indian industry, healthcare industry. So both these taboos are not there, So as I understand, there's some reluctance would be on the part, because healthcare is not, very lucrative, given the current state. The claim ratios are high, But some limited, restricted cover can be developed, to begin with, because numbers will be less, Over a period of time, numbers will increase, So the product will become viable at the end of the period, over a period of time. So a consortium of the insurance companies, local health insurance companies, PSU companies, they combine together, put together, because this industry is currently about $1 billion, So if you look at the premium, it will be at least 10 times of it, about $10 billion, So the industry will just double, health industry in India, if we just use and exploit this opportunity, you know. So that's what, it's an opportunity definitely missed. There's lack of understanding, you know, how. Now the challenge will come in on the distribution side, you know. There are ways of distribution. Technology is one of the efficient way of currently, you know. If a product is approved by IRDA, Indian image is good, especially in Africa and overseas, you know. So if IRDA product is approved, it can easily be sold through, you know, distribution channels, you know, online. Then we can have partners overseas, like local insurance companies overseas, you know. They can share the risks and they can repatriate the chunk part of the risk if their appetite is not sufficient to absorb the capacity, you know, because insurance companies in Africa, their size of capital are low, you know, but still it can be distributed through those tie-ups, you know, like Tanzania, Canada, you know, New India can take a lead, and we can be distribution partners for them, you know. In Kenya and Tanzania, we have a presence in Nigeria also of the New India owned subsidiary, you know. So we can begin with, there's a need to think and exploit that opportunity through this channel and mechanism.
I have a question for Priya ma'am. Is it possible for any foreign national, definitely when we travel abroad for during the travel, business travel or any tourism, we do get insurance, international tourism insurance. But is it possible to get for any foreign national to get an insurance in another country for a health coverage?
Are you talking specifically of India or coming to
any
India?
Or any other countries that allows
Yeah,
you?
that's a good question. Actually, we don't have products where someone is actually traveling to India as a tourist and then approaches an insurance company and says, you know, I want health insurance cover during my stay here. The reason is the current regulatory framework does not permit cover for less than a year duration. But having said that, you know, a lot of things are being revisited. I'm sure all of you have been following all the changes that have been happening in the, you know, regulatory space in insurance. We are moving from rule-based to principle-based, and for example, especially for the insurance industry, when it comes to certain areas, we have eased a lot of things. So similarly, when it comes to product design, I'm very glad that a couple of dignitaries here raised the issue of product design. Yes, everything revolves around product design, and designing the right product, a need-based product, I think is really the need of the hour. But just to, I'm glad you're here. In fact, I am an ex-New Indian myself. I'm from the 1986 batch. I moved to the regulator's office subsequently. And I'm glad that you raised this issue of, having an opportunity, not in terms of what foreign insurers can provide, basically recognize Indian expenditure towards healthcare in India, but whether we in India, whether the insurance companies can offer a product for tourists visiting India. But if someone is visiting our country as a tourist, I can see scope for giving a product. But if someone is visiting India purely for medical treatment, I can't give a product because that's not insurance. So I will end up charging as much as I pay. So that possibility is not there. But yes, if like I said, we are revisiting some of our framework, and the product, minimum duration of the product is something we are certainly looking at. So that, I suppose, does it address your question? Yeah.
Madam, I would like to add, I think, my words were different, the product is an annual product, which we are talking, So that product is not just for a specific period for travel, In Africa, healthcare industry is, in a way, is at a very old state of, and most of the advanced treatments, most of them travel here, So most of the products which are sold, they allow treatment in India, but on referral basis. So there is no institutional framework. Okay, what I am talking is to develop a product which will be sold to foreigners for the full period of health, which will respond like in a limited way locally for like this is an emergency, it will be stabilizing for an emergency, and then it will be, so it will be a full annual product, not a limited period product, There are existing products, all international, Aetna, Max, Allianz, they are offering that, So it means, we need to rethink and revamp, that there is a possibility existing, and the numbers and the numbers on the medical value tourism, is really very attractive, and it's an opportunity,
That instance where you can give a product where he knows that I'm now not getting into the hospital.
Yeah.
Basically what I'm saying is I can't buy a policy on the way to the hospital. But yes, there is scope where you can probably cover people who are living abroad, who visit India off and on, under an annual cover. But like, if I may, just extend on this, like it has been discussed, I think there needs to be a convergence. We are largely guided by FEMA when it comes to, the payment methodology and all of that. So there has to be a convergence, whether it's the RBI, the government, the IRDA, all of us, to look at, portability of products across borders. Just to give you a little background, with your permission, on portability in India. So before 2016, the concept of portability, even among the products in India, for the products in India, did not exist at all. But in the year 2016, we introduced that. And so today, one can move from one product to another product of another company. But because the design of products can vary, okay, the things that can actually be ported is, today the pre-existing disease definition in India is defined as up to 48 months. That is, up to a 4-year waiting period is permitted. If a company wants to have a lesser period, they can have that. And the second thing is, if there is cumulative bonus that one has gained under one product, that can also be carried forward. So there are certain, the portability is limited to this, but still it is a beginning. So what I'm saying is, at least the concept of portability is now understood. And yes, it is time that we look at whether we can actually implement portability across borders. That would require all agencies involved to come together and discuss. I do understand that there is a council, I think, for the MVT that has been set up, and insurance, we are also represented there. That could be a good platform to discuss this. And IRDA would definitely, be there to contribute in whatever way it can from the regulatory perspective. We all agree there is scope, and I think we need to leverage on that.
Good afternoon, ma'am. My name is Danish. I'm the CEO of Health Trip. We are one of the largest health travel platforms in the world. I'm also part of the MVT committee you mentioned, and I was part of the Chintan Shivar held last year. We've been trying to closely work with insurance companies to launch a product, as my friend from Tanzania mentioned, where a Bangladeshi can pay annual premium for health coverage in Indian hospitals only. The only problem where it gets stuck is on the KYC in Indian address is required. And that is where the insurance companies are not able to issue. For example, Care Insurance, Star Health, we're closely working with both. They want to launch a product, we are willing to distribute it, we are willing to get the premiums to India, pay the premium. We have figured all that out. The problem is where the address is concerned. If there could be some relaxation on that single point, this product is ready to launch.
In fact, KYC has become a very important thing now. In the general insurance industry, it was not as much administered as it was in the life. But now it is equally applicable to general insurance companies, which basically includes health as well, and also the standalone health insurance companies. I think that is something, because we are all driven by the act that governs that, and even our guidelines have to be in basically in sync with that. So let us also discuss with the concerned authorities, and let us see if there can be. I mean, there has to be KYC, but in what manner it can be done, I think we can certainly look at it.
Please, go ahead.
Thank you, Mr. Chairman. Earlier on, you raised the issue of what can be done, say, by governments. I think one of the ways that can be done to solve is to have, in India, for instance, you do data analytics. The hospitals can analyze who is coming from which country, how they are paying. With that data, you can then approach a country, for example, and say, look, we've got more of your members coming through. What can we do to help? I know from a Zimbabwean perspective, our government has been very good, even in hard times. the central government, you know, the Reserve Bank, has always put aside monies for those who are coming for treatment because it's important and because they have the data to say how many of our members are going to India, for instance. So it's one of the things that can be done by India to do that data harvesting, the analytics, and then you approach those governments. So you can actually help the insurance companies there to have regulation done in favor of them for the members. Thank you.
Okay, all these are policies and stuff, but the reality is that no matter how good your product design is, no matter how, the cost of travel is a major issue. Because then it's either going to increase the premium such that it is not attractive, and sometimes not even just the cost of travel, but the convenience of traveling. Typically from Africa, you've got to transit through some other country to get to India, right? There are no direct flights. So then it becomes easier to go to a South Africa, which is a direct flight, or to Dubai, which is a direct flight, as opposed to coming to India. So if India is affordable, but the cost of travel and the convenience of travel negates it, there's no way portability can help the medical travel because it's just not there. So it's another aspect that we need to look at. I don't know whether it is the countries that are going to have direct flights or I don't know what. But the cost of travel is a major issue here. If you're not able to deal with the cost of travel, then you can have the portability, the product is there, everything is fine. But then how do I move from Africa to India? The cost of travel alone may negate the whole, whatever savings you are hoping to have, even though the quality is good, but then you cannot afford to move here. So that is another angle that has to be looked at somehow.
I'm sure there are many more challenges that we have to address in coming time, but we have just started with on the right front. And if there are a few last comments or any suggestions, please go ahead before we close.
Thank you so much. I'm Azam from the Maldives, and I'm the Managing Director for Asanda. And I'm just listening in, and we may not be considered conventional insurance per se, but I'm really inspired to see that the region as well as India is going towards assisting more participation for countries who are embarking through insurance-based participation in the health service seeking aspect of the region per se. So I think in that manner, Asanda, even Maldives as a country, is also embarking towards working towards participation or redesigning Asanda in a way that it could be contributory as well. Right now, it's a free healthcare for all Maldivians equally, with no distinction between the whole population per se. Now we are talking about medical travel in the Maldives right now, and I think one of the key take-homes on this gathering that I have also come across is that now we are talking about medical value travel, and I think that is something that we are really interested in, and to make sure that value for money is there for the services that we are getting is something that we would really be looking forward to as well. And I would just a comment, I wanted to open up and invite Indian TPAs to also come and approach us for participating, for taking services from Asanda through Asanda for hospitals in India as well. Right now we are doing mostly direct agreements with the hospitals as such. We will continue to do so, but I think there is some element of what we call value identification that would come from getting TPAs involved in the process as well, because as you know, we are not a very huge country, so the numbers matter in terms of insurances and also in terms of measuring quality as such. So I think it's a bit hard for us to gauge quality when we send only very little number of patients per year for specific procedures. So I think I just wanted to, put it out there and invite all TPAs that are registered with proper bodies of the government of India to approach us, and feel free to, provide your details and, provide your propositions for taking services through Asanda, for the Maldivians to get treatment in India as well. And I really thank the organizing bodies for inviting us, and also I think I'm really inspired to see that in the discussions had actually opened up a lot of hope for us in the future as well, to have potential participation of our individuals who are able to, or who can actually buy insurances abroad, to buy those packages within India directly as well. Now, as you know, we are almost neighbors as such, where travel is easy, and maybe sometimes getting from one state to the other within India takes longer than coming from Maldives to India. So I mean, that would really open up the scope for Maldivians to participate in insurance programs, and that would be really a wonderful opportunity for us as well. Thank you so much. Yeah.
I'm sure when we look at One Earth, One Health, there is a need for one insurance as well. That's what I think we are heading towards, and hopefully in coming times. So, having said that, many good things came up. I think on the right front that we need a larger level policy dialogue and collaboration between the government to government led, with participation from industry and also equal participation from the patient, so that all the aspects of this are covered and addressed and planned. Also very important that the products that we have not only defined from a local geography perspective, from a global products, which could be enabled by IRDA and similar organizations in the other countries, and those products can be sold in the respective countries, and citizen can pay for the premium, and they can avail such international products if they are enabled by the local insurance providers and the hospital providers. There is also important aspect of hospital to hospital tie-ups, because the continuum of care is very important, and if the hospital to hospital tie-ups are there, for example, X hospital in India having a tie-up there, the pre-hospitalization, diagnosis, a lot of other aspects can be covered, and before patient flying here for a procedure and going back, the post-hospitalization care can be managed, and the entire treatment can be considered as single instead of considering as partial treatment from different providers. So there's a larger portability is required also from the provider side of it. That's very important. Also, standardization of various aspects of quality, accreditations, documentation is a very important aspect in terms of what kind of coding that we follow. In terms of the document that we manage, pricing aspect is very important, has to be standardized, transparency and regulated and governed. Also from health insurance claim action perspective, that could be extended across the geographies, that could enable a seamless claim management as well as the payment mechanism and the management of it. It's very important and aspect. As rightly said by one of our colleague here, is patient convenience has to be most important aspect. Patient is already having a challenges in terms of medical challenges and managing, but important thing is that how we all stick together and bring the convenience aspect as a core of this, what we are trying to design and do that. Lastly, I think it's very important that the medical value travel council that has, and as a part of this committee, this could be further extended, whatever some of the points today have emerged. The discussion has just started. We should continue and carry forward. Hopefully we should see some of those things getting implemented and initiated by across the geographies and all the stakeholders here. Having said that, ma'am, last words from you before we close this.
I think you've summed up the discussions beautifully already, but a couple of points which I'd just like to appreciate. The point about data and analysis is well appreciated. In fact, we have an organization called the Insurance Information Bureau of India, where transaction level data from the industry is collected. I think it's a great opportunity to see if we can leverage on what they're already doing and build. That's a great idea. Second, about the travel. In fact, I was in another session just to bide my time, and this was precisely being discussed there. And they said that the Ministry of Aviation, Civil Aviation, was to be present, but for some reason in the last minute it got cancelled, because they are a very. The cost of travel is a very important aspect, but talking of policy design, because even in the overseas medical products that the insurers in India give, they try to bring in a lot of add-ons which can cover. So one way of covering these expenses is, can an insurance company which designs a product for health also have an add-on for the travel if there's a need? So because the products that we have in India, for example, somebody falls sick abroad and emergency treatment is given there, but if they need to undergo further treatment in India, the policy covers the travel of that person back to India. So maybe it's largely a question of how can we design something to suit. And also the basic principles of insurance, I find, are getting modified, and it's getting modified for the better. We have to move along with the times. So I think there is scope to be innovative there. I think rest of it he has already summed up, but I'd just like to mention about the tie-ups. I think a couple of you did mention that we should have insurance companies coming in, and so while I'm not against that idea at all, because a lot of insurance companies even internally are servicing directly, they are having arrangements with hospitals and not going through TPAs. But I think the existing infrastructure and the facilities themselves are not being utilized. And there is an example of a tie-up of one of the TPAs with an African company already. So I think there is scope to leverage further on that, but I do take your point. And your point about the product and the scope is well appreciated. I was looking at a short duration product, but I do now understand that you are basically referring to an annual product which someone abroad will take. I think that's a great idea as well. But there are issues across cross-border issues which we may need to sort out in conjunction with other agencies. I think I've enjoyed the discussions we've had today, and a lot of things I have noted, picked up, which I'm sure I'll go back and recontemplate, and I'm sure all of you will do the same. So with this, let me thank each and every one of you, for your participation, and I would like to thank the authorities for inviting me here today and having the opportunity to discuss this with all of you. Thank you.
Thank you, ma'am. Thank you, everyone, and really thank you to each one of you for being participating in this and providing your inputs. It was wonderful having you all. Thank you very much. We'll close this session. Thank you.
And I'll be in touch with you.
So you're operating out of Delhi? Who? Yeah, we've been talking to KPMG, we've been talking to...
But I remember this one engagement that he did. I'll catch up with you.
Recently joined Ken India MD.
Oh, Ken India. You're for Tans India. But Muralidharan, who was there earlier, Tans India, he was with me in the team.
Okay, IT guy.
Yeah, IT. I was at New India head office. So that's nice. Mr. Sandesh.
My batchmate was reporting to Satish.
Oh, Satish, okay, United India.
Yeah.
We are doing something similar to this there.
Wonderful, wonderful.
We need our PSU.
You are in the right position to tell your chairman come managing director. She is my batchmate. Not yours, the New India chairman come managing director. Nija is my batchmate.
So you are Indian based?
Yeah, Indian based batchmate. All good. How are you?
It's a pleasure to listen to you every time.
I would love to reach out and sometimes connect with you. I'm part of the core committee also.
Okay. Actually, I was in health earlier and then I went to non-life. I'm back in health now.
How can I connect with you, ma'am?
My number, yeah, 9347 006995. Thank you so much.
You already have my madam. Is there any you would like insurance companies or regulators or for hospital there should be a regulator?
That we take up in see, unfortunately in India, it's a state subject. So every state has got its own. But now really the industry is working towards a common burden. Today what is happening, the same hospital is in different times. So we, through the council, are working on a common burden network where there will be only one network. So once we do that, we have much more leverage. Recently I've collected this data. How much income of the hospital is the insurance. You don't need a regulator. IRDA itself can do it.
Ma'am, I wanted to just make you one quick suggestion. If I'm going to US from here, I wouldn't think about not taking an insurance. When somebody is applying for an Indian visa, make a strong push that it's a good idea to take insurance if somebody is applying.
Most countries do that.
India is not there.
That's a great.
And the second thing is, so you can always grow the base. The second thing is when somebody is going out of the country, I know your point is absolutely right. You cannot sell insurance to somebody who is sick. But what if on the exit point you had an option to somebody to buy a 1 year or a 2 year?
That's the point.
It's exactly
So
the great point.
it's a great point. I didn't think of it from that angle.
It is like a great.
Restricted cover means emergency cover. What emergency happens overseas, then it is for
Design the
That is
product very carefully. I think the moral hazard point.
Yes, absolutely.
We want insurance companies to be viable to be able to pay claims. So that's always been our concern. It's been
Growing the
wonderful
base is a
talking
good
to all
idea.
of you. Keep in
Thanks.
touch.
Absolutely. Thank you. Center always you are.
Thanks a lot. Oh, you've been Thank you very much. And I want to thank Gaurav. Thank you very much. Yeah, thank you so much. Thanks for it's okay, carry it. I just need no, this is mine. I'll आपके पास है ना प्रवीण का एक बार I want to thank Gaurav. Yes, thank you so much. I was telling you the time I arrived.
ऑफिशियल क्रेडिट हो गया ना मेरा भी करना
गौरव भाई आपको बुला रहे हैं हाँ जाओ 1 नंबर गेट पे
I'm leaving in the morning. Thank you. But I think the Secretary General of the Council will be there, Mr. Inderjeet Singh.
He might be there in other
Which session is this?
this is CEO roundtable. Here, our secretary will be there, Chief Secretary. Then we have skilling session.
Do you have insurance companies there? Today's session, the original list I saw 4-5 insurance companies.
Yeah, but apparently
they did not.
The last one. Yeah.
No, I wasn't aware of this. Otherwise, I might have.
Okay, no issue.
Anyway, be in
बंद करना
वो सीवी आ रहे हैं सीवी
ठीक है
सीवी आ रहे सीवी नहीं सीवी चाहिए डन
मूव हो रहा है